आराम से कर लो तो टाइम मिलेगा। हाँ मेरे को मुझे पता ही नहीं था। ये हवा था ना सर मेरे पीछे को कैसे बढ़ता है, मैंने कहा सर मुझे दिख रहा है, मैं कैसे नहीं लिखूंगा। देखा है ना, और कैन टेल द लिटरेचर हमारा कितना है दिस कुछ है तो और आपको याद होगा सर में गया है हम करा के ओके दिखता है दिखता यार सब बढ़िया। अभी ना मैं क्या करूँगा, अभी यार डायरी लिखी सब कुछ वहीं की मैं इमीडिएटली अगर आपके साथ करेंगे, अब ये डायरी आपके ये हमारे पास हो गई, मैं इस तरह का प्रोग्राम बना रहा हूँ, मेरा डेटा क्रिएट हो गया तरह राकेश तरह हाँ हाँ करते हाँ मेरे वहाँ पे चले जाओ। हाँ, तेरा व्हाट्सएप को मैसेज भेजता हूँ। और हाँ, तो सर को सुरेश सर को बोलना कि यहाँ पे डिस्प्ले करें। राधिका,
Yeah, that's right. So when we start process with the
नहीं फर्स्ट वाला डिलीट कर दो ऊपर वाला।
So they took from my purpose for my I said we should not trust the purpose of the
Good morning, everyone. It is my pleasure to welcome you all to Day 3 of GIAN program, focusing on long-term follow-up and cardiovascular management in pediatric medium vessel vasculitis. I would like to acknowledge our guest faculty, Professor Etsuko Suda, who is a word authority on the long-term follow-up of Kawasaki disease. I welcome you, ma'am. Over the past 2 days, we have had insightful discussions and engaged in thought-provoking sessions led by many experts. Today, we continue this journey of learning and collaboration, building on the momentum we have already gained. So without further ado, we shall begin today's session, wishing you all an enriching and productive day ahead. So to chair the first session, may I please request Professor Manful Singhal sir to come on the stage. Sir is a professor of radiodiagnosis and imaging, Pgimer, Chandigarh. He is a distinguished expert in his field and has impressive body of work with over 200 publications to his name. I welcome you, sir.
Thank you, everyone, and welcome to this academic feast. And it's a day 3 of this GIAN program. And today we'll start with Professor Etsuko Suda, who I consider as a mentor to me, especially in the imaging assessment of coronary arteries in Kawasaki disease. Welcome, ma'am, and over to you.
Mr. Chairman and ladies and gentlemen, I greatly appreciate appreciate the opportunity to speak at this session. To evaluation coronary artery lesion caused by KD, coronary angiogram is invasive and expensive. Non-invasive MRCA has remarkably improved. Dr. Suzuki provided many slides of her many years' work for you. I present her works instead of her. Dr. Suzuki is a leader in MRCA imaging. The future of MRCA are able to detect not only coronary arterial lesion, but also arterial wall, thrombus and tiny constructions in aneurysm by using sequence blood method. MDCT cannot detect lumens severely calcified coronary artery lesions. Occlusion of the LAD due to thrombus in the aneurysm is shown. Coronary angiogram cannot detect arterial walls and hardly detect thrombus as a filling defect. Spiral blood method shows thrombus in the aneurysm. Spiral black blood method detects black lumen, gray artery wall, and white thrombus. There are three sequences. One is steady-state free precession, SSFP, and another is black blood method. In SSFP method, blood is high signal and white. In Vista BB, arterial lumen is black. In the spiral black BB method, arterial wall is gray. CMR can also detect localized stenosis and subendocardial infarction. Coronary arterial wall thickening in the aneurysm is shown by each method. Sorry. Sorry. Okay, sorry. Sorry, yeah? Okay. CAD to the intravascular ultrasound, black BB, SSFP, And sorry. Coronary artery calcification progress years and years after KD, and localized stenosis with calcification is detected. A stenosis of lumen cannot be often evaluated in such region by CTA imaging precisely. However, MRCA is possible without an effect of calcification. Dr. Suzuki presented changes in coronary artery aneurysm due to Kawasaki disease observed by series of MRCA. MRCA is non-invasive method. Good point for children, no radiation, no using contrast medium, no breath holding, no necessity of decreasing of heart rate. Sedation for children, all procedures take 40 to 90 minutes, and they were performed without the use of sedation and with free breathing in patients over 3 years old. Patients less than 3 years old are given sodium trichloroethylene phosphate syrup at 20 minutes before starting examination. Patients more than 3 years old until 8 years are administered intravenous injection as 5 times tripental sodium slowly until they fall asleep. Then sodium 1 solution is dripped very slowly during examination for the purpose of keeping infusion route. They were attached with a percutaneous oxygen monitor and observed by a pediatrician during examination. Follow-up MRCA was performed 267 patients. The age at first MRCA ranged from 4 months to 42 years with a median of 8 years. Each coronary artery region is shown. Aneurysm, 208 cases. Localized stenosis, 43 cases. Occlusion, 19 cases. Recanalization, 29 cases. Within normal limit, 30. After AC bypass surgery, 12 cases. And after directional coronary atherectomy, 5 cases. This slide shows thrombosis, occlusion, and recanalization in the same patient. This slide shows perfusion defect and rate gathering enhancement in patients with occlusion of the LAD. Further, thrombus changed shape. This slide shows thick aneurysmal wall and developing vasovasorum. This slide shows thick wall and thrombus in spiral BB in a 24-year-old male. Further, lotus root-like artery was found. Recanalized vessels are shown in this slide. Further, localized stenosis appeared. This slide shows thrombus often change the shape and location in the aneurysm. The membranes and tiny polyps were found in the aneurysm. Membranes and tiny polyps were found in the aneurysm. Thrombus detected spiral BB. Thrombus developed thin membranous. Thrombus changed to tiny polyps. Thin membranous tubes are detected by intravascular ultrasound and recanalized vessel, so-called segmental stenosis. Turbulent flow in the aneurysm is rapid flow. Turbulent flow changed thrombus. Thin membranous tiny polyps were often detected in aneurysmal lumen. Fresh thrombus is not be able to detect it by two-dimensional echocardiography. Sorry. In this patient, turbulent flow also changed thrombi. In this patient, localized stenosis appeared in 28 years old. LG in the anteroceptal wall was detected and CAG was performed. The patient underwent CABG, coronary artery bypass grafting. Newly appeared findings during the follow-up period are shown. 8 patients underwent coronary artery bypass grafting, and 3 patients had directional coronary atherectomy. In summary, thin membranous in aneurysmal lumen and tiny polyps on the intima are detected. Recently, by benefit from the development of the VISTA-BB sequence, large thrombus often have a few tiny lumens and rings so-called lotus root-like artery. This may indicate the neovascularity in the thrombi. These contractions in aneurysms are unsettled, and even recanalized vessels also changeable even more than 30 years after the onset of Kawasaki disease. MRCA is most convenient for following up coronary artery lesions due to Kawasaki disease, frequently and non-invasively. Next, second talk is to evaluate coronary artery wall. Coronary artery wall injured acute KD inflammation. Coronary artery stenosis due to pathological walk thickening after KD. Intravascular ultrasound showing intermedial thickening in the coronary artery wall. Intravascular ultrasound showing various degrees of wall thickening. Severe wall thickening, slight thickening. This patient had aneurysm in the RCA. However, there was no coronary aneurysm of the LAD. There is no intimal thickening of the LAD and LCX after 15 years. The next patient had a small aneurysm at the bifurcation of the left coronary artery. At 15 years old, the small aneurysm had regressed. Slight intimal thickening was detected. In the 70 years old patient, slight intimal thickening was also detected in coronary aneurysms. This patient had an aneurysm at the bifurcation of left coronary artery. At 12 years old, aneurysm persisted. Slight intimal thickening was detected. In contrast, at the same site where a larger aneurysm had regressed, severe intimal thickening was detected. This patient had KD at the age of 4 months. A coronary angiogram at the age of 2 years revealed severe local stenosis of the left anterior descending artery. Intravascular ultrasound showed severe intima medial thickening. We measured the largest diameters of each coronary artery in the initial coronary angiogram within 100 days after acute KD. We see the relation between maximum CAA diameter at the initial coronary angiogram and intima medial thickness more than 10 years after KD. In the diameter more than equal to 4 millimeter, intimal thickening was found in 90%. However, in the diameter less than equal to 4 millimeter, intimal thickness was not found in 98%. The graph shows the relation between the maximum CA diameter at the initial coronary angiogram and intima medial thickness more than 10 years after KD. A significant correlation was found between the diameter of the coronary arteries in the initial coronary angiogram and intima medial thickness and intima medial thickness of the vascular wall more than 10 years after KD. This paper shows OCT, IVAS, and pathological findings OCT can evaluate intima, media, and adventitia. This paper shows coronary wall thickening is best without coronary dilatation in the acute phase. We see a case presentation. An 11-year-old male had KD at the age of 9 years. In the initial CAG 2 months after the onset of KD, maximum diameter at segment 6 of the left coronary artery was 10.9 millimeter. Wall thickening is decodable in aneurysm by DSCT. A 31-year-old patient had KD at the age of 5 months. In the initial CAG, 2 months after the onset of KD, maximum diameter at segment 1 of the right coronary artery was 10 millimeter. Coronary artery calcification is detected at the regress site after the right coronary aneurysm. This slide shows coronary angiogram 2 months and 1 year after the onset. Calcification of LAD was detected after 16 years old. Localized stenosis was detected. This graph shows the relationship between the maximum diameter of coronary arteries and the appearance of late coronary wall abnormality of DSCT in the branch group. The larger diameter, the more the late coronary abnormality. The incidence of CAC and calcification in coronary artery region gradually increase with aging. This table shows the cutoff point of acute coronary dilatation leading wall thickness and coronary calcification rate after KD. In the branch group, the cutoff point for 4.8 and 5.0 millimeter, respectively. In the LCA group, LCA bifurcation, the cutoff point for 5.3 and 6.7, respectively. The incidence of CAC in CAL segment of the initial coronary angiogram in male and female of the branches groups was shown in this slide. There was a significant difference by gender in the incidence of CAC. In summary, DSCT was useful to detect non-invasively late abnormalities in the initial coronary artery region segment. Acute coronary dilatation more than about 5 millimeter can lead to the abnormality of coronary artery wall in the early adulthood. The incidence of CAC in CAL segment gradually increased with aging, and there was a gender difference in the rate incidence of CAC at the CAL. Thank you for attention.
Thank you, ma'am, for taking us towards the recent advances in long-term follow-up of the coronary artery lesions. You see, if you have to see on historical basis, it was to begin with the capillary, and you see how the technology has empowered us to see these lesions non-invasively. Even though each imaging has its own advantages and usefulness, and you have to be very, very selective in selecting particular modality, either CT or MR, depending on the clinical. Yesterday also I reiterated, we came about to reiterate the same again here. I every patient is, every individual, every patient is different, and then the imaging has to be tailored according to the clinical needs and the type of the lesion. And Madam has explicitly demonstrated large calciums will take about the sensitivity and specificity of this examination, especially for the stenotic lesions. In those cases, MR can be done. And MR is a wonderful examination because of ethics more than coronary artery. You can see wall, and more importantly, you can see those lesions and from the myocardium as well. And I would like to ask you, did you find any myocardial abnormalities in your cohort when you did cardiac MR, other than infarction?
Function to stress perfusion.
What I need to say is, we say Kawasaki disease is myocarditis as well.
Yeah.
Did you find any myocardial abnormalities on follow-up?
We don't perform. Not perform.
Not found.
Yeah.
It's same are our results, myocardium, we didn't find any myocardial abnormalities in long term. So if there are any questions to ma'am or any thoughts or any ideas we can discuss with ma'am, whether probably the largest experience in the world of long-term follow-up. And ma'am, Dr. Gopika is sitting with me and she is working on long-term follow-up with cardiac MR. And Ms. Taranpreet is also with me, who is working on the cardiac MR. We are trying to see the coronary artery abnormalities and trying to see the myocardium as well. So we have performed around 25 patients as of now. And we are trying to correlate with microRNAs and the ISA-based tests. And let's see, once we complete our study, we'll let you know the results. With this, I conclude this session, and thank you so much, ma'am, for sharing your knowledge, vast knowledge on this aspect. Thank you so much.
To chair the second session of the day, may I request Professor Sujit Singh Sir, Head of Department of Pediatrics and our Chief Mentor, to please come on the stage.
Good morning. So we would now have a practical demonstration for which we would move up to the ward. But before that, we would have some theoretical discussion as well. So I would now request Dr. Saji Dhillon to start the discussion.
Respected Professor Sujit Singh and the organizing chairpersons for this wonderful CME program. It's my great privilege and honor to present this topic on point of care of coronary artery disease. Before that, I will request all of you to join Indian Society of Kawasaki Disease, take a membership, and just simply type in the Google Kawasaki Disease India or Kawasaki Disease Society. You will get the website, and you will get the QR code and the membership form. Please join. And this time the annual 8th conference will be going to be held in Kochi. So I welcome all of you to Kochi as an outing and Kerala tour program also. So most of the topics we already covered the coronary artery disease. So I will point out few things that if cardiac status is normal in the acute phase of KD, in general, no significant late major cardiac complications observed actually. So there are complications like acute complications and late complications. These acute complications, when you encounter, definitely your pediatricians have a doubt whether you should diagnose as a KD with the two criteria. Then definitely you have to add up to these two criteria and make it as confirmed diagnosis of incomplete KD and start treatment early. That's the reason we suggest that the ECG and echocardiogram, if it is available, if pediatric cardiologists are nearby, please suggest for an echocardiogram. We are not expecting coronary artery dilatation, but sometimes associated, as we heard yesterday, it's a pancarditis, sometimes evidence of valvulitis, or AR, MR, or myocarditis, LV dysfunction. This also can add as a heart involvement in Kawasaki disease. Not necessary, not necessary coronary artery involvement to add. If the criteria 1 or 2 are there, definitely if you are seeing evidence of myocarditis or valvulitis, then you should start on treatment. So there are acute cardiac complications, vasculitis, myocarditis, endocarditis, coronary ectasia, heart failure, KD shock syndrome, valvulitis, conduction system abnormality, because all the conduction systems are just beneath the endocardium. So anything happen to any inflammation to the myocardium or endocardium, this conduction system also can be affected, different arrhythmias can be presented. So the late cardiac complications, as you know, we already heard, I'm not going to touch. Thrombosis, aneurysm rupture, myocardial infarction, calcification, premature atherosclerosis. And remember, after 10 years only, atherosclerosis process can occur. So below 10 years, if any child come and ask, sir, can I eat egg and ice cream, etc., I freely suggest you take, don't worry. But after 10 years, there will be a slowly starting atherosclerotic changes in the edema. So that is the reason some of the cases, whether the statin has to be continued or not. So pointing out this myocarditis in KD, remember myocarditis is a well-recognized component of Kawasaki disease with left ventricular dysfunction. That's the reason I say that the early echocardiogram is really advisable, but the trained people can recognize early. So when you suggest a echocardiogram, most of the time adult cardiologists are doing, so that you just simply write, please rule out MR, TR, and calculate the ejection fraction, any effusion. You just simply point out so that the adult cardiologist also will stress on that particular point, even though they have not seen any Kawasaki disease. They will write, sir, there are mild TR, AR, MR are seen, or mild effusion are seen, or EF is borderline 60. Below 60 is normal for children. And below 60 is abnormal, above 60 is normal. In adult is below 55 is abnormal, above 55 is normal. So borderline, never rely on MOD. I suggest you, because MOD is outdated by us per our Indian Echocardiography Society and worldwide literature. If you see MOD is outdated, if you don't have the software for global strain echo in your echocardiographic machine, at least everyone knows, cardiologists and MD people are knowing that how to calculate EF by Simpson method. You can write it on the paper while you are addressing to cardiologist, calculate the EF by Simpson method. So the borderline EF also you should be careful with the rising titer of the N-pro-BNB. You consider as a subclinical myocarditis. If the EF is low and with the rising titer of the N-pro-BNB, definite evidence of myocarditis. So in KD, myocarditis develop even earlier than the epicardial coronary arteritis. It peaks by this is day 10 and then disappears gradually after day 20. So inflammatory cell infiltration consisting mainly of lobulated leukocytes and large mononuclear cells was seen in the myocardial interstitium in all cases. So clinical exam also very important thing. Know that clinical auscultation is a dying art. Nobody want to do nowadays with a stethoscope. Even in our ward also, juniors are never carrying the stethoscope at all. They are not, even in the outpatient department, nobody is allowing the child to in a supine position and examining. It was had actually. Simply open up the mouth with a torch, seeing the throat and writing some medication. No. Clinically, you never, you have to examine head to toe. Then only we can identify the axillary pulsatile aneurysms or any the femoral artery occlusion, etc. Lot of things has to be find out. Clinical examination is very important thing. So gallop, tachycardia, tachypnea, pericardial rub, evidence of congestive heart failure, liver examination. Nobody is doing that nowadays. Palpation of the liver, no. It's so sad actually. Everybody looking at the X-ray, okay, pneumonia, okay, start on antibiotic. No, that practice has to be stopped and we have to, clinical examination is very important thing. Otherwise your next generation will be totally out. Most often acute phase will be in subclinical phase. That's what I said. If the rising titer of N-pro-BNB and evidence of some valvulitis and EF is in a borderline 58 or 57, I consider like a subclinical myocarditis. Definitely we will start on treatment. So this is the initial time, some 4 cases they published and they found that all cases had EF was reduced to 44 to 51. And ECG changes, as I said yesterday, the ECG also important thing that early pericarditis can be detected. So that even that also you can add, the pediatrician had only 2 criteria are whether we should include in incomplete or complete or whether we should diagnose KD or not. Then I say that it's not necessary, that is my opinion. It's not necessary coronary artery is involved, then only you can add 2 plus 1 so that 3 by 5 consider as incomplete KD and start treatment. If the evidence of thrombocytosis, rising titer of N-pro-BNB, CRP is high, ESR is high, at least eye congestion and redness of the mouth and 2 criteria is already there, then if you are seeing evidence of pericarditis without echocardiogram, then you should say that you start on treatment. If you have a doubt of the financial difficulty, at least they can start on IV MB methylprednisolone. So this is the there are a stage 4 in pericarditis evidence in ECG. Stage 1 is actually easily to detect. That's why I said as soon as you diagnose and admit in the hospital, you please see the ECG. It is easy. There is a sagging of PR segment. And the M pattern, I drawn like this, M pattern, whereas convex elevation is ischemia. And this is the M pattern, if you are seeing, it's evidence of pericarditis. Whereas in stage 2, it will be resolving slowly. And stage 3, T-wave inversion will come. Stage 4, almost like ECG is normal. So early, stage 1, you can pick up pericarditis. So this is my case, actually one. This is showing that M pattern, definite pericarditis. So again, the same M pattern I am showing. So definitely MRI is the choice for the gold standard for detecting the myocarditis. But just to rule out myocarditis, we never send the cases for MRI. Severity of detecting edema in myocardium in acute phase of myocarditis is 84% with a specificity of 75%. So multiple foci of the hyper enhancement of myocardium during early gadolinium, Dr. Manful Singh has already discussed all these things, and this is consistent with myocarditis. But clinically, if evidence of N-pro-BNB, N-terminal brain natriuretic peptide. By BNB, the stability is very few hours only. So N-pro-BNB will be little more stable. So that's why N-pro-BNB you have to write very clearly. Sometimes you people are writing BNB only, they will do, lab people are doing BNB only. So in myocarditis, definitely N-pro-BNB you clearly write, and most of the lab will show sometimes higher level, we don't know. That is the reason, very next day I will repeat. If any rising titer is there, definitely evidence. So with the evidence, echo shows some pericardial effusion or EF is borderline or much lower 50% or MR or TR, then definitely you consider as myocarditis. EF is normal and N-pro-BNB is higher, then I consider like a subclinical myocarditis. So diagnosis of myocarditis in children is based on combined, including lab, echo and confirmatory investigations. So this slide I myself made with H&E stain during my immune complex vasculitis I made in the swine. I inject a horse serum. You know, horse serum will make a type 3 hypersensitivity reaction, and that is the only agent will produce circulating immune complex. So I clearly proved that this is a circulating immune complex vasculitis, whether triggers are SARS-CoV-2 or some other factor, but the pathogenesis will be like a immune complex vasculitis. So you can see the mononuclear and lobulated leukocytes in the pig myocardium. I proved that even myocarditis occurred in the pig muscles also. This we published in the journal. Cardiovascular biomarkers of myocarditis, I already said. High sensitivity tropi also, or cardiac troponin I, CKMB, and ND-BNB. And when the titer is average, above 300 picogram, especially with the rising titer, and with the evidence of some ECG changes, suggests that this is a case of a myocarditis. So this normal value, you can take a short note. The neonates, remember, up to 3 days, even up to 6,000 can go up. So don't be panic. And if next day, if you are doing again, it's a rising titer to 7,000 or 8,000, consider. Whereas 3 years to 6 years, above 327 or 350 is significant. Above 350 picogram is significant for 3 to 6 years. Even 12 months to 3 years, also above 600 is significant. So age dependent varies with the N-pro-BNB result. So that you should definitely consider. So these are few just showing some pictures showing the pericardial effusion and the paradoxic motion of the IVS, and global strain is very important thing. For that purpose, we advise to take 3 views. One is a 4-chamber view, 2-chamber view, and 3-chamber view. Now the software of the newer machine automatically will calculate within maximum 3 minutes only will take. So machine also varies. G will give below -20 is significant. In Philips machine, below -25 is significant. That's what we observed. So in this case, definitely this is the Simpson method I showed. You take a dual picture. One is in diastolic period and one is systolic period. You just simply trace it and you get the EF. EF here is 55% and the strain much reduced. Average global strain become -11. So this global strain is high sensitive and we can pick up the early myocardial change. So tips for early identification of myocarditis in KD, signs of the heart failure, ESR, CRP, NPRO-BNP, TROPI, and baseline echocardiogram. See for evidence of valvulitis, MR or TR or AR, any evidence of pericardial effusion, EF estimation, mainly by Simpson and global strain study. So I just showed you some slides on myocarditis because already we heard about the coronary artery dilatation, etc. Thank you. Thank you so much.
Thank you, Dr. Sadi. So the next speaker is Dr. Avinash Anandkar.
Pendrive is there.
So, good morning, everyone. I thank you for this opportunity. So, it will be a short talk because primarily it was a hands-on session. So, we'll just run through the slides to see how to assess LV function as a point of care in KD. So, I bring greetings from Pondicherry, and there are certain devices which are now easily available to do a point of care ultrasound. So, most of us are familiar with vendors GE and Philips. So GE provides a V-scan, which is just a handled, just the probe alone comes. So this is the probe. So we can carry it in our pocket and can pair it with our own mobile phones. It's available both in Android and iOS platforms. And on Bluetooth, whatever images we are seeing on in the Echo machine will be on your phone, and you can transfer it in any mode that you wish. And like primarily for our LV function assessment, we'll have the adult probe. Pediatric probe is presently not available, but they have other vascular probe and probes that are used for assessing fetal echo also. So similarly, Philips has brought out their device, so which is being a screen also is provided with them, like which is similar to a iPad. So this is not compatible with the phones, but both are almost at similar cost of around 7 to 8 lakhs. So this will considerably reduce the space occupied in emergencies and will be actually a point of care ultrasound. So how to assess LVEF? A rough assessment will be given by M mode. So we do a parasternal longitudinal long axis, and once the long axis of the LV is obtained, perpendicular cut of the LV is made. Usually the plane is kept distal to the mitral leaflet tips, and once a perpendicular cut is obtained, we can assess the LV cavity size, that is the LV internal dimension in diastole and systole, and the interventricular septum thickness in diastole and systole, and the LV posterior wall thickness in systole and diastole. So the EF given by this method is the Teichholz method. As Professor Sajay Phillips mentioned, it is not the recommended method now, but it can roughly give you an idea of the EF by eyeballing, and we can get a rough estimate if there is a LV dysfunction in a particular child or not. So the problem with this method it assesses the LV at a single point. So supposing a child is having a myocarditis, it may not have a global LV dysfunction. Certain patchy areas of myocarditis might be there. So supposing we take a LV cut at a different point, we may wrongly allude that the LV function is normal, and when actually there is a LV dysfunction. So LVEF by Simpson's method is the ideal method, and most of us are familiar with doing that. So there are two portions of the Simpson's method. So apical 4-chamber view in end diastole and end systole, and apical 2-chamber in end diastole and end systole. So the 4-chamber view is going to give us the single plane Simpson's EF, and when we do the apical 2-chamber additionally, it gives you the biplane EF. So ideal is to do the 3D EF so that it gives the complete spherical volume of the LV, and we get the EF. But this is at least equivalent in that 2 frames of the LV function is assessed by the biplane Simpson's method. So the LV is divided into 20 discs so that it gives the volume, the height as well as the width, and the volume of each disc is calculated, and that gives us the rough ejection fraction by Simpson's method. So global circumferential strain, the problem with EF is it is image dependent, and it is also angle dependent. Circumferential strain and longitudinal strain are parameters which have improved upon the EF in that they are angle independent. So if the initial criteria was that ECG was mandatory for acquiring strain, so the images should be ECG gated. But subsequent softwares have evolved now that without ECG also we will be able to get a strain. So in order to get a global circumferential strain, we need to get the LV cut in the parasternal short axis in 3 different planes. So the first plane here shows the at the mitral valve level, so this is at the papillary muscle level, which is the mid LV cut. So here we are able to see the mitral valve level, so that is the basal level, and the subsequent cut is at the apical level. So at these 3 levels we take a LV cut, and then once we do the global circumferential strain, that gives us the GCS at all the levels. And then this is the global longitudinal strain, which is a more accepted parameter compared to the global circumferential strain, and most labs use this parameter to assess the LV function. So here, apical 4-chamber view is taken first, and then the apical 2-chamber view is taken. So all these are at the LV apex. And then the LV 3-chamber view is taken. Sorry. So and then the LV 3-chamber view is taken. So once these 3 views are taken, care should be taken to get at least a minimum of 3-beat acquisition in each of these views. And once this is done, the software gives us the longitudinal strain. So it is not only available for LV, it is also available for RV. Previously, it was not available as a independent software, so we were employing the LV strain for the RV. So RV being a different structure, it was not giving proper values, but now both Philips, Siemens and GE have provided separate strain software for the RV. So this is the RV strain separately for the RVs, particularly useful in children with pulmonary hypertension. I am not aware of its role in KD. So LV mass, we can assess LV mass in case of regressed LV, particularly useful in children with transposition of great arteries who are presenting late to assess regressed LV. To assess the mass, we need to feed in the body surface area also so that we get the indexed body mass. So once we begin the echo, if we enter all these parameters, we get a indexed body mass for the child. So it is calculated by the area length method where apical four-chamber in end diastole, we get the length of the LV and the mid-cavitary width. And in the short axis view at the mid-papillary level, tracing is made at the endocardial level and the epicardial level so that the myocardial area is obtained. So then the LV mass is calculated using this formula. So TAY index or the myocardial performance index, it is a measure of both the global systolic function and the diastolic ventricular function. It is applicable both for LV as well as RV. So it can be done by two methods. One is by the pulse wave Doppler in the apical 5-chamber view. So once we get the apical 4-chamber view, if a pulse wave Doppler is applied, we will get the mitral inflow here as seen by the E wave and the A wave. And subsequent to that, the mitral valve closure happens, and this is all the events during the mitral closure. So once the mitral valve closure happens, there is a phase where the aortic valve is yet to open. So that is the isovolumic contraction time, that is the IVCT. And subsequently the aortic valve opens and then the LV ejection happens. So that is the LV ejection time. Subsequent to the LV ejection time, there is still a time period where the aortic valve has already closed, but the mitral valve is yet to open. So that is the isovolumic relaxation time, IVRT. And subsequent to that, the mitral valve again opens and then the E wave, that is the early phase where the passive LV filling happens. And after that, the atrial booster pump and then the A wave happens. So if we have a ECG gating, we can time these events. So there is a P wave, and along with the P wave corresponds the A wave of the atrial booster pump. And the end diastole is marked by the QRS complex, and then subsequently the parameters which happen during the mitral closure time, that is the LV ejection, all correspond to the end of T wave, which signifies the end of systole. So this can not only be done with pulse wave, it can also be done using tissue Doppler imaging. But many of the point of care ultrasound devices may not have tissue Doppler imaging. So we must and most of the point of care ultrasounds will have pulse wave Doppler, even if they don't have continuous wave. So applying the pulse wave in a apical 5-chamber view will give a picture where you are able to capture the E wave and the A wave as well as the ejection time if you place the sample volume midway between the mitral valve and the aortic valve. Supposing we place it only at the mitral valve, we get only the mitral inflow parameters. So we'll see this in the hands-on session today. And the normal LV TAY index is less than or equal to 0.40. So values above that are significantly abnormal. So we are more interested in regional wall motion abnormality. This is one area in pediatrics like KD, because if there is a giant coronary aneurysm in a particular coronary artery, and supposing the child has had an infarct because of a thrombus, then knowing the regional wall motion abnormality will help us pick up the involved territory. So this is the apical 4-chamber view and the apical 2-chamber view. So apical 4-chamber view, the areas given in green are supplied by the right coronary artery. The areas given, they are the numbers are the LV segments given by the American Society of Echocardiography. So in the 17 segment LV model, what are the numbers? Those correspond to the numbers given here. So the yellow zones are the areas supplied by the left circumflex, and the red zones are the areas supplied by the left anterior descending. So the 17th segment is the true apex, and the 14th is the septolateral. So these are supplied by the LAD. And in the 2-chamber view, the circumflex is not supplying any zone. The entire lateral portion is supplied by the LAD, and the septal portion is supplied by the RCA. And in the parasternal long axis view as well as the apical 3-chamber view, the distribution is similar. So most of the time we try to get a apical 3-chamber view for the LV global longitudinal strain. And in cases where it is not easily possible in certain children, we may opt for the parasternal long axis view, which is an equivalent of the A3C. So the entire posterior wall is supplied by the LCX, and the interventricular septum in this view is supplied by the LAD. And the RV obviously is supplied by the RCA. And in the short axis cuts in the basal LV, so they have given a depiction of the mitral valve in cross section. So the anterior and anterolateral are supplied by the LAD. The inferior and infroseptal are supplied by the RCA, and the lateral and anterolateral are supplied by the LCX in the basal portion. Similarly, in the mid LV, the distribution is similar, LAD, RCA, and LCX, and in the apical LV also, the distribution is similar, whereas the apical cap is supplied by the LAD. So we can give a wall motion score index also in case the wall motion abnormality is identified. So supposing there is normokinesia in each of the 17 segments, so the entire score index will be 17 by 17, so it will be 1. But supposing a child is having hypokinesia in particular area, for instance, this particular example, this child is having a hypokinesia in the apical anterior and apical septal, and in the mid anterior and mid septal. So the score is given as 2 for the zones which are hypokinetic, and the true apex is akinetic. Probably this is the distribution of the LAD territory. So the child has had some problems in the LAD territory, and these have gone into a hypokinetic phase. So, but the true apex is already scarred and it is akinetic. So I mean, summating the scores, this particular child will have a value of 23/17. So any instance where the wall motion score index is more than 1, it is an abnormal score, and there are certain segments which are hypokinetic. And 3 is akinesia, 4 is dyskinesia. Like dyskinesia is where the rest of the LV moves together. For in a systole, all the portions of the LV are contracting together at the same time, whereas one particular segment is going away. So that is dyskinesia. And aneurysmal segment is grossly dyskinetic, and it moves totally abnormally. Most often in the LV true apex, we find aneurysmal LV in case of a LAD related infarction. So this will be the rough assessment of this one. I don't have direct experience of assessing children with KD and LV function. The closest we have done is multisystem inflammatory syndrome in children. So we assessed the clinical profile and outcomes of this children initially, and that was published in JPCH. And there was a longitudinal follow-up of these children, this cohort, with echocardiography. And we found in GLS, there was a serial assessment of these children at admission, 6 weeks and 3 months, where initially there were segments which were grossly abnormal. This is the entire cohort's LV strain, and subsequently became better by 3 months, but still some portions were abnormal. So summarizing, point of care echo devices are ideal in pediatric setup and emergency setups where we need to screen children for LV function and probably coronary assessment if we have suitable probes for coronary assessment at the bedside. Presently not available with point of care systems. And LV ejection fraction by M-mode is not a great idea, but it gives a rough assessment of the LV, but Simpson's, especially biplane Simpson's, is the recommended method. LV global longitudinal strain is a good parameter, but it's always better to have ECG gating so that even if the particular machine does not have the capability to do a LV strain, a ECG gated DICOM image can be transferred to a workstation, and a strain can be done subsequently. Global circumferential strain is not well validated in children, but the LV myocardial work is the upcoming next thing, where it is like LV strain is angle independent, but it is still load dependent, whereas myocardial work is also load independent. But it is a proprietary item of GE Healthcare, so it is not available with Philips. So, but this may be an upcoming parameter in LV function assessment. So, thanks for your kind attention. I'm wishing happy learning in the upcoming talks. Thanks.
Thank you, Vilash. We would now move on to the ward for a practical demonstration and hands-on on the echocardiogram.
I request all the interested participants to kindly proceed to echocardiography room APC 4B ward for our next hands-on session.
I will check. Sad. Yeah.
It's this one or next one?
Yeah. Later I changed. Sorry. Sorry. I check. quantitative gated spade. Left ventricular ejection fraction. The evaluation of ventricular arrhythmia was based on Holter electrocardiogram at the same time. We divided the 100 patients into 3 groups, depending on ventricular arrhythmia. 1, none or PVC, knee couplet. 2nd couplet. 3, non-sustained ventricular tachycardia, NSVT, or ventricular tachycardia, VT group. Extent score. The definition of extent score is shown in this slide. Short axis images of left ventricle were obtained after reconstruction. In each short axis image, ischemic regions were analyzed circumferential area. Hyperfusion less than 2,000 standard deviation from the mean was defined as an ischemic region, and each area was extent score. Extent score was automatically calculated by QPS software. The patient is a 24-year-old female. She had repeat MI. Extent score was 22%, and LVEF was 49%. NSVT was detected. In this slide, the relationship between the extent score and ventricular arrhythmia is shown. The vertical axis indicates the extent score, and horizontal axis indicates the interval from the onset of KD to MPI. Yellow circle crosses indicate no arrhythmia or single PVC. Blue square denote couplet and orange marker denote NSVT. As you can see, orange marker cluster in the right upper area. This table shows the clinical characteristics of each ventricular arrhythmia group. In the NSVT group, note the long interval from the onset of KD, the higher extent score, and low LVEF. Next slide shows the result of multivariate analysis. Extent score was the most significant marker for the prediction of NSVT. The cutoff value for extent score predicting NSVT was 11 points, and the interval from the onset of KD to MPI was 17 years. In summary, the factors related to the appearance of NSVT in patients with CAL caused by KD was the interval from the onset of KD and extent score. Case presentation. Here we see an adult patient in detail. A 34-year-old man visited hospital because of headache. An electrocardiogram revealed an abnormal Q wave in lead to poor progression in V1 and V2, and flat T waves in V5 and V6. Electron beam CT showed a calcified giant aneurysm Coronary angiogram revealed segmental stenosis of RCA and occlusion of the LAD. He had had unknown fever at the age of 10 months. At the age of 43 years, he attended the hospital because of fever and palpitation with a common cold. An electrocardiogram revealed ventricular tachycardia. His MPI is shown. Asymptomatic interceptor and posterior inferior myocardial infarction was suspected. Extent score was 24%. LVEF was 39%. In treatment, coronary artery bypass grafting was done and an implantable defibrillator was inserted. Next, I talk relation between the rate gadolinium enhance and ventricular ejection fraction in CMR. LG indicates fibrosis of myocardium. Transmural extent of rate gadolinium enhancement, LGE, is shown by yellow area. The grade of LGE is based on transmural extent hyperenhancement. We analyze the relationship between the degree of LGE and ventricular fraction, and diastolic volume index, and systolic volume index, ejection fraction of the right and left ventricles. We divide it into 4 groups based on the trans extent of LGE. Grade 0 and group 0. Grade 1 is group 1. Grade 2 is group 2. Grade 3 and grade 4 is included in group 3. This slide shows grade 1, a 33-year-old female had CABG in 19 years old. This slide shows grade 4, an 80-year-old boy, and AMI and coronary artery bypass grafting at 8 years. This slide shows coronary angiogram. Her left LAD was occluded, but collateral arteries, RCA, from RCA to LAD. In this patient, transmural extent was grade 2. Patient population is shown. 65 patients included. The age at CMR ranged from 5 years and 47 years, with a median of 29 years. The interval from KD to CMR ranged from 3 months to 3 years to 43 years, with a median of 20 years. Occluded vessel 172 to 127 to 24, 3, 3. Previous myocardial infarction was found 17 patients. Coronary artery bypass grafting was found 36 patients. Results are shown. There was no significant in right ventricular function, but there was significantly difference in the left ventricular function. In 4 groups. The results are shown. Previous MR was found in group 2 and 3. On the other hand, coronary artery bypass grafting was in all groups. There was a significant difference between LGE grade and LVEF. In summary, existence of LGE more than or equal to 5% in the myocardium suggests adverse remodeling of the left ventricle, although LGE was found in more than half of the study patients with ACAO, the transmural extent of LGE was less than 50% in most of them, and their global LV function was preserved. Global LV function in the patient with CALS by KD was usually preserved. And this paper is published. Grade of LGE enhancement in ACAO, asymptomatic coronary artery occlusion, and myocardial infarction group, showing a significant difference between groups. Grade of right gadolinium enhancement and left ventricular function. In MI group, left ventricular function was significantly decreased, but ACAO, in patient with ACAO, left ventricular ejection fraction and LVEDVI was not always decreased. In patient LV function in patient with ACAO is preserved. Thank you for attention.
Any questions, any comments? I have just demonstrated there are 3 comments, maybe the take-home messages. That the infarction that occurs as a mark of due to the coronary artery problems, maybe stenosis, thrombosis are territorial. And the extent and variability are variable to views. The rule of the thumb is any infarction greater than 50% is viable. Anything which is more than 50% is not viable. And that's how the LV works. And then the infarction is more than 50%, 50%. What I will be reversible is that Madam Nicole also slides that once you do CAP, also the functional recovery is not possible. So even with the 50% is the rule of thumb. Anything below 50%
you. Yeah, thank you, thank you. Yeah.
Just wanted to ask, before any intervention, whether it is cath or surgery mainly, is there any way that we would know that this is a viable marker or this is a non-viable marker? Can we know the coronary?
Yeah. For indication, coronary CVD intervention. Yeah. Yeah. I do coronary flow reserve by transthoracic echocardiography. I use, but FFR, CFR in cardiac catheterization, the value, cutoff value, is not always appropriate for adult patient case. Uh, 2.0, cutoff point 2.0.
In the resting coronaries or after exercise?
Yeah, I don't do.
Thank you.
Any other comments? So, thank you, ma'am. Thank you again.
So we move ahead with the next session, that is the oral presentations. We have 8 oral presentations in line. So we look forward to the interesting cases and engaging discussion. For chairing this session, we have Professor Tapas Sabul and Dr. Saji Phillips. I would like to call upon our first speaker on the dais, Dr. Ananta Nandi, sorry.
GIAN is the first, yes, yes. Change. Next, laser. Which is the light? Mark. Okay, this is next. Okay. Good afternoon all, my respected teachers and judges. Oh, sorry. Privileged to present this case today in front of the learned audience. So my case is clinical profile of coronary artery. Sorry, sir. Okay, sir. Should I start, sir? Okay. My case is clinical profile of coronary artery aneurysm at diagnosis of Kawasaki disease, a retrospective observational study from a tertiary care center in eastern India. So as we all know, Kawasaki disease is an acute systemic vasculitis, is a leading cause of acquired heart disease in children. It is increasingly being reported from India and other countries as well. Detection of coronary artery aneurysm at diagnosis is crucial for treatment intensification and to reduce morbidity and mortality. So objective of our study is to note the number of coronary artery aneurysm at diagnosis of KD, note the frequency of aneurysm in different coronaries, and to note the number of small, medium, and giant aneurysm in different coronary arteries. So it is a retrospective observational study conducted in Institute of Child Health, Kolkata, over a period of 4 years from January 2020 to July 2024. Children less than 18 years and diagnosed as KD as per AHA 2017 guidelines were included in the study. Aneurysm was detected by using ECHO, Dallaire et al. System we used, and score more than equal to 2.5 was taken as aneurysm. Patient with congenital heart disease and those who received treatment for KD prior to admission as excluded from the study. So among the 130 total KD patient included in the study, 51 had coronary artery lesion at diagnosis. 2 had only dilatation, 49 had aneurysm. So in our study, we got almost 38% has coronary artery aneurysm at diagnosis, among whom 23 had single aneurysm and 53% patient has multiple aneurysm at diagnosis. Gender distribution, male to female ratio was 2.7:1. Median interval from the onset of fever to the detection of aneurysm was 9 days, and median age at diagnosis of aneurysm was 14 months. Among the 49 patients with aneurysm, 25 was complete KD and 24 was incomplete KD. Total number of aneurysm noted among these 49 patients was 101, because many patients has multiple aneurysm. Distribution of these 101 aneurysm into different coronaries. LAD has the maximum aneurysm, 44, followed by LMCA, which has 29 aneurysm, and RCA has 28 aneurysm. Circumflex artery did not have any aneurysm in our study. The distribution of aneurysm according to size, there are total 76 small aneurysm, 23 medium, and 2 giant aneurysm in our cohort. And LAD being the leading artery in both small and medium, followed by LMC, RCA. The both giant aneurysm occurred in LAD only. So to conclude, about 38% children with Kawasaki disease had aneurysm at diagnosis. Male has significantly more aneurysm than female. More than half of the aneurysm, that is up to 53.06%, had multiple aneurysm at diagnosis. Among the coronary artery aneurysm patient, number of complete KD and IKT was comparable, almost the same. Aneurysm were more common in LAD, followed by LMC and RCA, and giant aneurysm was detected only in LAD. So this is my institute where I belongs to. I am sincere thanks to my whole pediatric department of my institute. Thank you all.
Is there any reason why the incidence of coronary artery lesion same in classical and incomplete?
Sir, median duration, median age was 9 months. Almost all were infant. That can be one reason. Complete KD, maybe the detection rate is better. We are detecting aneurysm in the complete KD. The patient are not missed.
Your patients are classical and incomplete. You have already made that.
Yes, yes. Sir.
Why the incidence is almost same?
More aneurysm are getting, nowadays we are getting more aneurysms. And that duration is also during the COVID time. So there are lots of patients are coming with multiple aneurysm as well.
After giving IVIG or before giving IVIG?
No, sir, these were at presentation.
Because the standard, the publication says that after the IVIG, incidence is less, and without IVIG, around 24-26%.
Yes, sir.
Your case that 8%.
Yes, sir. That was at presentation before giving IVIG. Actually, we did not wait for the echo. We gave IVIG. The first echo showed that. Preferably, it was done within 24 to 48 hours of the diagnosis.
That means all your patients developed aneurysm within 3-4 days, which is actually not very common.
Yes, sir. We have 130 total patients.
No. I'm not asking of the number. But you are saying that majority of our patients 3-5 days, 6 to 7 days. Classically, aneurysm doesn't occur in that period.
Yes, sir.
Then how do you explain that?
Cases, I think it's all referred cases.
Yes, sir. Most are small aneurysm, but definitely there are increased number of median and giant also. Though the median age of detection was 9 days.
Thank you.
Request Dr. Riasan to come on time for the next presentation.
Good afternoon, one and all. I am Dr. Riya Singh and I will be presenting my case series on coronary thrombosis in Kawasaki disease, a comparative data pre and post COVID period. Coronary thrombosis is a well-described complication in Kawasaki disease, usually in giant coronary aneurysm after 2 weeks of disease onset. This case series of 7 patients over 17 years with multiple coronary artery aneurysm and thrombus aims to compare
the pattern of coronary thrombosis before and following the pandemic. So we have 7 cases, 2 were pre-COVID and 5 were post-COVID. The first case was 10-month infant diagnosed with complete Kawasaki disease, developing thrombus on 18th day of illness with giant coronary artery aneurysm in all 3 arteries. Treatment was given, but unfortunately we lost the child during thrombolysis. The second case was 1.5 month infant presented with KD shock syndrome, developing thrombus on 14th day of illness with giant aneurysm in LAD and clot in LAD. Treatment was given and there was regression of thrombus and coronary artery aneurysms by 2 years follow-up. The next case was post-COVID. It was a 3-month-old infant with complete Kawasaki disease, developing thrombus on 26th day of illness with echocardiography showing medium coronary artery aneurysm in LMCA and LAD. The treatment was given and persistent coronary artery aneurysm was there with resolution of clot at 6 weeks of follow-up. The second case post-COVID was a 2-month-old infant with incomplete Kawasaki disease developing thrombus on 15th day of illness with giant coronary artery aneurysm in all 3 arteries. The treatment was given, here the treatment was given with streptokinase, clopidogrel and warfarin as well, and there was persistent coronary artery aneurysm in all arteries but no clot at 18 months of follow-up. The third case post-COVID was a 9-month infant with incomplete Kawasaki disease and the thrombus here developed on 5th day of illness with giant coronary artery aneurysm in LMC and LAD. Treatment was given and the thrombus resolved but aneurysms persisted. The fourth case after COVID was 6-year child with incomplete Kawasaki disease developing thrombus on 9th day of illness with giant coronary artery aneurysm in LMC and LAD. After treatment, the thrombus resolved but aneurysms persisted. The last case was a 9-month infant with incomplete Kawasaki disease developing thrombus on 11th day of illness with giant coronary artery aneurysm in LMC and LAD. After treatment, the thrombus resolved within 20 days of illness but aneurysms persisted. This image is of case 4 with giant aneurysm in left main coronary and left artery, anterior descending artery with marked increase in perivascular echogenicity. So our observation was that following the pandemic, we have observed an increased incidence of thrombosis, and post-pandemic, almost 4 out of 5 patients had earlier onset within 2 weeks that sometimes progressed in spite of the therapy. Post-COVID, there has been an increase in reports of vasculopathy and vasculitis. Although this was a very small study, but can we speculate this evidently increased incidence of thrombosis to be part of same spectrum? Thank you.
What is the reason?
Sir, we exactly don't know the reason, but it could be because of the COVID virus itself, or I feel there is more awareness and more detection of the cases now as compared to the 5-10 years back. So,
Any of your patients have COVID positivity?
no sir, we have not.
Then how can say?
Sorry sir?
Then how can say that is due to COVID?
Sir, it's just our observation post-pandemic, what we are seeing in patients, but we have not tested.
Anything happening after the epidemic will be post.
Yes, sir.
Epidemic itself has caused damage, or itself is a response positive factor, then you have to prove it.
No, sir, we have not done that.
Antibody titer done, no? So then you get some idea, even though the first and the paper will be having sometimes RT-PCR positive or negative. And laboratory parameters are not mentioned actually, about the platelet situation and other relations.
Sir, actually it was a retrospective study, so all this was not done initially, and this is just our observation after all the cases have been there.
You observe the thrombosis part.
Yes, sir. Thank you, sir.
I request the presenter to wait KTK because we have to give marking.
Next we have Dr. Sumti Verma.
Good afternoon to all present. I'm sorry. Should I start, sir? Yeah. Good afternoon to all present. Our study is on clinical profile and outcome of Kawasaki disease. It's a single center experience from a tertiary care referral center of Punjab, North India, that is DMC Ludhiana. But as we know that Kawasaki disease is an acute febrile illness of childhood that is seen in worldwide in all populations, but now we see that it's more in Asian background as well. KD is a vasculitis that with a predilection of the coronary arteries, and approximately 20 to 25% of untreated patients experience coronary artery abnormalities, that is aneurysms. It's the leading cause of acquired heart disease in children in most developed countries, especially USA and Japan. In the last decade, more and more cases are being reported from different parts of India, but a large number of cases are still being missed due to ignorance among physicians about this disease. So that's why we conducted a retrospective study of cohort of 50 patients with Kawasaki disease over 5 years. That was conducted in our department. Data was retrieved from medical records of patients admitted with KD, collected from 2020 to 2024, and it was statistically analyzed. The results showed, first I'll present the demographic data. Our common age group was 1 to 5, and we had more male preponderance. The fever was present in all 100% cases, with rash as the second most common symptom, followed by conjunctival changes and extremity changes. Then type of aneurysm, most commonly we saw a small aneurysm, followed by medium aneurysm, and then dilatation, which was calculated as per the Z-score. Then we did the correlation with coronary involvement, different correlations like the age group. There was no significant correlation found between age group and gender and coronary abnormality. With grade of fever also no a significant p-value was found, but with duration of fever we could see a significant correlation which showed that less than 7 days was significant if more coronary abnormalities was found. And then we did a subgroup division as well, where it was found that less than 14 days there was more coronary abnormality that was found. Less coronary abnormality was found in less than 14 days, more than 14 days more, and with a significant p-value. There were no significant changes with oral changes and rash, and no significant correlation with lymphadenopathy as well as extremity changes, and no significant with conjunctival changes as well. So we did a follow-up also. The follow-up was done in 72% of cases, and out of those follow-up, we found that 10 patients had aneurysm. All patients who had aneurysm earlier, 33 patients out of 50 had aneurysm. Then all those were followed up, only 10 had aneurysm where size decreased. So cardiovascular manifestations can be prominent in the acute phase of illness and are the leading causes of morbidity and mortality. They develop in 20 to 25% patients with untreated KD, and it is associated with a mortality rate of 1 to 2%. It was associated in pre-IVIG area, which decreased to 0.08%. Deaths are most common 2 to 12 weeks after the onset of illness and are usually secondary to coronary aneurysms. So in our study, we found that fever, rash and non-exudative conjunctivitis were the most common clinical features. Rash was seen in 64% cases, where we saw with the other series. It was less because probably our cases reported late. Parents were not aware of rash, they were kind of fleeting rash and had atypical presentations. IVIG and aspirin was given in all our patients. In this case series, we found that duration of fever had most significant correlation with the coronary abnormalities, and 30.3% had aneurysm on follow-up, but all aneurysms reduced in size, and there was no mortality found in our study. So our conclusion is that this disease needs to be considered as a differential diagnosis in an acute febrile illness in children persisting up to 5 days. Fever more than 7 days, especially after 14 days, is significantly correlated with coronary abnormalities, and hence early diagnosis is important to prevent morbidity as well as mortality. Thank you. So that this should be considered as a differential diagnosis, and if it is missed early, we miss it, then as we have already seen here, that the long-term morbidity is very bad and we have sudden cardiac deaths, which is unexplained. So this has to be more and more, there should be a more and more knowledge about this, and it should be considered as a differential diagnosis if fever is persisting more than 5 days and we are not finding any significant cause.
What is the reason of all your aneurysm disappear?
They all did.
You said all your patients are late.
Sorry, sir?
You said all your patients arrived late. You said receive treatment late. Still all your patients improved.
Sir,
as far as the aneurysm is concerned, is there any reason?
Sir, the only reason of the rash was probably they reported late. So the percentage of rash is less, but the patients who received IVIG and aspirin, we saw on the follow-up that the size of the aneurysm reduced, and the aneurysm, the children who had small aneurysm and dilation, their aneurysm disappeared. It was the only reason of the late reporting was mentioned as rash, but otherwise they all improved on follow-up.
Institutional evaluation also is very important thing to compare with the data of the
Yes.
publications. And most of them are correlating, and take home message, I found that the fever more than 7 days was well correlated with
Yes, sir.
coronary artery involvement.
Coronary artery involvement. Yes, sir. Sir, and I want to mention one thing. Our echocardiographer is the constant person. He's like, he only did the previous, and because he's the one who has the maximum experience with this. So the echocardiographer was common in pre and post follow-up. Yes. Thank you, sir.
नेक्स्ट कौन है कौन सा ये वाला जैसे ओके करेंगे उसके बाद
Good afternoon once again. I'll be presenting our study on outcome of Kawasaki disease patients treated with corticosteroids and IVIG. Use of steroids in the treatment of acute Kawasaki disease was described by Dr. Tomisaku Kawasaki. RAISE, that is randomized controlled trial to assess immunoglobulin plus steroid efficacy for Kawasaki disease study based on Kobayashi score to predict IVIG resistance, revived interest in the use of steroids. The aim of our study was to evaluate the response in patients treated with steroids in addition to IVIG and low-dose aspirin. Material and method was, it was a retrospective observational study from January 2020 to October 2024 in Institute of Child Health, Kolkata. Children diagnosed with Kawasaki disease as per AHA 2017 guidelines were treated with IVIG, low-dose aspirin, and patients with any of the following features received additional oral prednisolone and were enrolled in this study. Patients having Kobayashi score more than 5, patients with IVIG resistance and persistently high inflammatory marker 36 hours following IVIG, presence of myocarditis, dilated coronary arteries and small coronary artery aneurysms. KD patients with coronary artery Z-score more than or equal to 5 and treated with infliximab prior to the corticosteroids were excluded from the study. The results were as follows. 145 children were diagnosed with KD during the study period, of which 51 received corticosteroids. Median age of recipients was 17 months and there were 31 males and 20 females. Median time for IVIG administration was 8 days. The median time for corticosteroid initiation was 10 days from the onset of fever. 29 patients out of 51 received steroids for small aneurysm, 8 out of 51 for dilated coronaries, 2 out of 51 for presence of myocarditis. 7 out of 51 patients received corticosteroids for Kobayashi score more than 5, of which 4 continued to have fever and later received infliximab. 5 out of 51 received steroids for persistently high CRP following IVIG along with clinical signs of ongoing inflammation such as oral mucositis. Of the 29 patients who received corticosteroids for small coronary artery aneurysm, 7 progressively increased to medium and rest 22 small coronary artery aneurysms and all dilated coronaries regressed after a median duration of 21 days. The limitation of our study was it was a single arm retrospective study with small sample size. So we conclude that corticosteroids can be used for the treatment intensification in KD patients with dilated coronaries. However, 57% patients who received steroid based on Kobayashi scoring needed therapy augmentation and 24% patients with small coronary artery aneurysms progressed to medium size. Thank you.
You have covered all patients who received IVIG?
Yes, sir.
Neither blood were received only 27%.
Sorry, sir?
How many patients received either blood alone?
No one received alone, sir. Every patient received IVIG and these were added, steroid was added based on Kobayashi score mostly.
From what are the points you have mentioned, any more limitations do you think is there?
I can't think of anything, sir.
Your number is small.
Yes, sir.
And you stratify your patients so much stratified and so much varied, very difficult to analyze the result.
Okay.
That's a weak point of this study.
Okay, sir.
Question is, and you have given steroid at different times.
Post IVIG, sir. On like yes, the
8 days sometimes 10 weeks, 10 days.
yes, sir.
Someone got time of 2 weeks. Someone received at the beginning of the therapy.
Yes,
there
sir.
There is a wide variation in small size of cohort.
Yes, sir.
Okay, thank you.
Thank you, sir.
Next, laser. जजेस का बोलने के बाद शुरू।
ठीक है।
Good afternoon, everyone. I, Dr. Rosie Bhardwaj, JR at Dr. R. Pgimer, Danda. I am presenting a study of comparison of the clinical profile of Kawasaki disease in below and above 6 months of age. Firstly, the background. Kawasaki disease is an acute inflammatory condition that primarily affects children under the age of 5 years. Younger than 6 months often present with atypical or subtle signs which can make diagnosis more challenging. The typical features such as rash, conjunctival injection, or oral changes may not be as pronounced. Fever in infants under 6 months may be the only obvious symptom, which makes it harder to differentiate from other febrile illness. Since infants below 6 months often lack the typical finding of KD, thus they are more likely to be misdiagnosed or diagnosed later in the disease course. Delayed diagnosis is linked to higher rate of coronary artery abnormalities. Study objective. The study analyzed the differences in the clinico-demographic and lab profile of Kawasaki disease in patients below and above 6 months of age. The study is a retrospective study analyzing the case records of KD patients at Dr. R. Pgimer, Tanda. The patients were grouped into two, Group A and Group B. In Group A, the patients were below 6 months of age, and Group B includes the patient above 6 months of age. This study compares the clinical symptoms, laboratory markers, and cardiac findings. First, the demographic details. In Group A, which includes infants less than 6 months, in this, the male to female ratio was 6:1, and Group B, which includes children more than 6 months of age, the male to female ratio was 2.5:1. The mean age at diagnosis was 5 months in Group A and 45, that is 3.7 years in Group B. In Group A, all the patients were of incomplete Kawasaki disease, and Group B, 57 of incomplete and 43 of complete Kawasaki. Comparing the clinical symptoms, in Group A, which less than 6 months of age, the fever duration was 9 days. The mean duration in Group B was 7. The rash, which was 52% in Group A, and in Group B, that the mucocutaneous symptoms were more as compared to Group A. Comparing the laboratory parameters, in Group A, that is less than 6 months of age, there was seen thrombocytosis, ESR was raised, and coronary artery abnormality was seen in 57%, and in Group B, only in 15% were seen. The key results, the total cases which were taken was 53, diagnosed with KD. Mean age at diagnosis was 3.2 years, and the fever duration was 9.5 days in Group A and 7 days in Group B. The classic mucocutaneous signs were less frequent in Group A. The CA incidence was 57% in Group A and versus 15% in Group B. Conclusion, the KD in infant under 6 months is harder to diagnose due to incomplete symptoms. They have a higher risk of prolonged fever and coronary artery abnormality requiring early intervention. Early suspicion and diagnosis are essential to reduce the cardiac complications. Timely management is crucial, especially in developing countries like India. Recommendation, we can have early suspicion and vigilance. There can be prompt diagnostic evaluation, and we can enhance focus on laboratory markers and use of echocardiography in younger patients presenting with prolonged fevers, and awareness and education for the healthcare providers. Thank you.
Coronary ones are more common below 6 months of age.
Yes, sir.
So in such case, we will give any immunosuppression?
Yes, sir. We give IVIG, methylpin, and infliximab in patients.
And you give steroid and infliximab?
Sir, yes, sir. Sir, when we detected the coronary artery abnormalities, aneurysms on echocardiography. Sir, after the diagnosis of Kawasaki disease. Sir, with IVIG. Yes. Sir, internally, methylprednisolone pulse therapy was given. Sir, pulse therapy with IVIG.
Only pulse, single dose pulse?
Yes, sir. Sir, 30 mg per kg per day.
Single dose.
Yes, sir.
Okay, thank you.
Thanks.
Our next presenter, Dr. Ananta Nandi.
ओपन कर दिया है यही है ना बिजी हैं जजेस थैंक यू ये पॉइंटर है
How many cases, how many times you are going to present?
Sir, this is the last. I had 2 cases, sir. Should I start, sir? Good afternoon, sir. My presentation is Kawasaki disease presenting with pneumonia, a diagnostic dilemma. So we know that Kawasaki disease is a medium vessel multi-system vasculitis that predominantly affects children younger than 5-year-old. If left untreated, about 25% of the patient develop coronary artery aneurysm. Diagnosis of KD is based predominantly on clinical features supported by some laboratory investigation. Infant can have incomplete KD. About 41% of the incomplete KD has been reported in India. And about 15 to 20% of the patient can have atypical features, making the diagnosis even more challenging. These are the references. So my first case is a 1.5-year-old male who presented with high-grade intermittent fever for 5 days with cough and cold and mild redness of lips and tongue for 4 days. And he had breathing difficulty and lethargy for a few hours before admission. There was no history of conjunctivitis, loose stool rash or swelling of the hands and feet. On admission, that is on the day 5 of fever, child was sleepy and tachycardia, tachypnea was there, child was febrile, saturation was 88% in room air, and there was subcostal intercostal retraction and fine crepitations on auscultation. Hemoglobin was 8.8 and CRP was very high, 222 to 5 milligram per liter. Urine analysis shows sterile pyuria. So initial X-ray showed bilateral patchy opacities. Child was started on 2 broad spectrum. Child was already on 2 broad spectrum antibiotic and nasal cannula oxygenation 2 liter per minute. On day 8 of illness, that is 72 hours after starting antibiotic, child became afebrile, sensorium improved but became very irritable, and mucositis and tachypnea persisted, and oxygen requirements was almost same. CRP became 52, blood culture by that time came, it was sterile. So this is the repeat X-ray which showed worsening 72 hours after starting antibiotic. So on day 9 of illness, next day, child developed these features, sheet-like peeling from the feet and the periangular discommission. And perianal redness was also there and child was very irritable. Repeat investigation showed increasing platelet and ESR was 142. So a diagnosis of incomplete Kawasaki disease was made. Child was started on intravenous immunoglobulin 2 gram per kg over 10 hours and aspirin 5 milligram per kg per day. Antibiotics were stopped at this point. Echocardiography initial was normal. 48 hours after completion of the IVIG infusion, there was no irritability, child was maintaining saturation at room air, there was no distress, platelet showing increasing trend, CRP became 7.2 milligram per liter and X-ray showed remarkable improvement. And follow-up echo at 4 weeks was also normal. My second case is a 2-month-old female child who presented with fever for 6 days and cough and cold for 5 days and greenish loose stool with perianal excoriation for the same duration. Child had respiratory distress 1 day prior to admission, developed. Initial X-ray was right-sided, suggestive of right-sided lobar pneumonia. Child was already on 2 broad-spectrum antibiotics and nebulization therapy. At admission, child was anemic with a hemoglobin of 7.1, CRP and ESR was high. So, on admission, that is on day 8 of illness at our center, that is 48 hours after IV antibiotics, child was having fever with saturation of 87% at room air, subcostal intercostal retraction and bilateral crepitations. So, child needed PICU admission and nasal cannula oxygen and needed a 1 unit of PRBC transfusion also as hemoglobin was 7.1. Antibiotics were upgraded at this point because already 48 hours of antibiotic was done and child's chest showed worsening. Oseltamivir was also added empirically. Lumbar puncture was done as a workup of the fever and CSF study was normal. By that evening, child developed this rash, these macular rashes on the back mainly. So investigation was repeated on the same day, which showed increasing trend of the platelet. It became 10 lakhs and CRP became 192. When asked, mother gave a history of redness of the left eye without discharge, initial 2 days of illness and swelling of the feet for 1 day on day 4 of illness. The same day we noted this crusting at BCG site. So a diagnosis of complete Kawasaki disease was made. Child was treated with IVIG and low dose aspirin. Antibiotics were stopped at this point. After 48 hours of completion of IVIG, X-ray showed marked improvement. There was no oxygen requirement, no irritability. CRP was showing decreasing trend. So below one was the previous, sorry. Very sorry. So lower down one was the previous X-ray and that is the 48 hours after IVIG infusion. Cardiography initial and through 8 weeks was, 6 weeks was normal. So highlight of the cases, both were infant presented with features of pneumonia and treated with multiple antibiotics before diagnosis of KD. They did not respond to broad spectrum antibiotics. Features of KD developed subsequently in the first case and there are some features in the history when we asked in the second case. So Monedero et al. Showed that chest radiograph finding in patients with KD are uncommon, about 20% in acute phase. Singh et al. Showed that only 1.83% of the children diagnosed with KD had predominant pulmonary presentation. Another study, Lee et al. Reported 15% of the KD patient with concurrent pneumonia. So the question remained, pneumonia in the presentation of KD, a syndrome or a sequelae of the two diseases. But to conclude, KD may mimic pneumonia, hence it should be suspected in pneumonia unresponsive to broad spectrum antibiotics. So careful history and monitoring of the patient is very important as clinical features of KD can be transient or evolving. Thank you, sir.
Whenever the lung is involved, any organ can be involved in KD.
Yes, sir. It's a systemic vascular.
Investigation, X-ray also included, and these consolidations like that. So it's good to know sometimes in the era of the SARS-CoV-2, lungs are more involved also.
Okay.
You could have done antibody to SARS-CoV-2 also in this case. You know the triggering agent. Infectious agent causing KD.
But one is 2 months old, one is 8 months old. Both were infant. They born after COVID. After COVID.
It's a take-home message.
So the take-home message is KD can have varied presentation. It is a multi-system vasculitis. So pneumonia can be a presenting features. So before hiking up the antibiotics, we should look for the other features. We should even ask the mother regarding the features of KD which may have appeared previously. At admission, we may not find the all features. And before hiking up antibiotic, we should exclude KD definitely. We should think of it. We should vigilantly look for that. Thank you, sir.
We have Dr. Sujit John.
Next, this judges के बोलने के बाद.
Shall I start, sir? A very good afternoon, everyone. My name is Dr. Sujit Matthew John, Junior Resident Pediatrics from Pgimer, Chandigarh. I will be presenting an interesting case entitled A Silent Storm, Missed Kawasaki Disease in an Infant, presenting with giant coronary aneurysms, myocarditis, and peripheral gangrene. As we have heard multiple times already, Kawasaki disease is a medial vessel vasculitis, predominantly of children younger than 5 years of age, and it is currently the most common cause of acquired heart disease in children. Atypical or incomplete presentations of KD are more common among infants. Symptoms may often be transient, thereby precluding a prompt diagnosis and treatment. Even despite appropriate treatment, infants less than 6 months of age are more common to develop coronary artery abnormalities. Here I present a 3-month-old girl child from the Tri-City who presented with an acute febrile illness following her routine 6-week vaccination. Following this, she developed a generalized maculopapular rash which started over the trunk and progressed to the extremities. It was also associated with a non-purulent conjunctival injection and lip and oral mucosal changes in the form of redness, cracking of the lips and oozing of blood, and redness and strawberry tongue. For these complaints, she was taken to a local practitioner where she was treated with oral 3rd-generation cephalosporins. Her fever subsided within 4 days and her other complaints resolved within 7 days. However, following this, the mother noted that she had skin peeling predominantly over the distal extremities. She remained well for a duration of 3 weeks following this illness. However, after this, she developed a new, well-defined erythematous facial rash and gangrenous changes involving the toes. When she presented to our pediatric emergency at this point, she was noted to be irritable and she was tachycardic. She had a new, well-defined rash over the malar regions. As we can see in this image, erythema had subsided following administration of intravenous immunoglobulin. She was also noted to have gangrene involving the first and second toes of both feet, and skin peeling of the distal extremities was also noted as shown in this image. Laboratory investigations and admission revealed a normocytic normochromic anemia, leukocytosis, thrombocytosis, ESR of 26, a raised CRP, and a highly elevated pro-BNP level of 50,611. Coronary artery imaging was done at admission. A 2D echocardiography done at admission revealed a giant aneurysm with a Z-score of plus 15.04 involving the left anterior descending and medium-sized aneurysms involving the LMCA and the right coronary artery. During the course of our admission, a CT coronary angiography was done as shown in this image. Here we see a complex coronary aneurysm involving the left main bifurcation with extension into the osteoproximal LAD and the left circumflex as seen here. We also see 2 distinct aneurysms involving the mid LAD, which was again a giant aneurysm, and another aneurysm involving the proximal right coronary artery. Given a diagnosis of Kawasaki disease, she was given intravenous immunoglobulin at 2 gram per kg on day 1 of admission. Immunosuppression was intensified with pulse methylprednisolone, which was given at 30 mg per kg per day for 3 days, followed by prednisolone at 2 mg per kg per day. She was also given cyclosporin and infliximab at 10 mg per kg. In view of bilateral lower limb gangrene and giant coronary aneurysms, she was given therapeutic dose anticoagulation with low molecular weight heparin, and she was given antiplatelet doses of aspirin. However, during the course of her admission, she developed hemodynamic instability in the form of lethargy, poor peripheral pulses, and prolonged capillary refill times. She was managed with intensive care measures involving an IV fluid bolus, vasopressor and inotrope infusions, and she required non-invasive ventilatory support. With these measures, she gradually improved. She was given a second dose of intravenous immunoglobulin, 1 gram per kg in view of myocarditis, and prior to discharge, she was started on beta blocker and atorvastatin. She was discharged in a stable condition on tapering doses of prednisolone, cyclosporin, aspirin, therapeutic doses of LMWH, propranolol, and atorvastatin. She came for review last week, and a follow-up echo revealed that she had persistence of the aneurysms with some interval decrease in size of all 3 aneurysms. My message from this case is that prompt recognition and timely treatment of KD are crucial to prevent the devastating complications of KD as we see in this case, and a high degree of suspicion is required to make the diagnosis, especially with incomplete or atypical presentations in infants. Thank you.
Yeah, definitely your case report was a learning lesson for everyone, especially presented with the redness of the tongue and they started with the early antibiotic. Yes, it is a very important thing. For your information, when you show the face of the child, the eye should be black out. lung has to be one of the legal issues. And that is an important thing, early diagnosis is important.
At what point of time the patient got admitted?
So this was on day 28 of illness, sir.
Now you have given steroid to this patient.
Yes, sir.
How did it help you?
Sir?
How did it help you?
Sir, initially when she presented to us, she was hemodynamically stable, but later she developed instability also. And yes, sir.
That is, you have mentioned the AMI.
Yes, sir.
You have given steroid at 20 days.
Yes, sir. Yes, sir. Sir, but when she presented to us, she was noted to have active myocarditis. She had ST depressions involving all 6 anterior leads, and she had troponin T elevated. So we noted that she had active myocarditis, and she probably had signs, she had giant coronary aneurysms to us. So we realized that she was an active disease. Her CRPs were elevated, ESRs were elevated, and she was lethargic also, sir.
Thank you.
Now we have Dr. Tanya.
Next, laser.
A very good afternoon, everyone. I am Dr. Tanya Singla, Senior Resident in the Department of Pediatrics, AIIMS Delhi. So I would be presenting 2 cases today on coronary abnormalities beyond Kawasaki disease. So coming to the case 1 was a 2-year-old girl who presented with features of fever for 4 months and intermittent abdominal pain for the last 3 months. On examination, she had stage 1 hypertension, pallor, and hepatosplenomegaly. Rest of the systemic examination was normal. Coming to the course before presenting to us, child was already managed with multiple oral and IV antibiotics, and she had anemia, neutrophilic leukocytosis, thrombocytosis, and raised inflammatory markers. Before presenting to us, she already had an echo which had shown coronary dilatation, and already she had received 1 dose of IVIG at 2 gram per kg, oral steroids and aspirin. On presentation to us, she had persistent fever and abdominal pain. So, echo done at our center had revealed coronary dilatations with RCA and LED showing moderate dilatations and LMCA showing mild dilatation. So, in view of stage 1 hypertension and persistent pain abdomen, we went ahead with CECT abdomen, which had shown multiple splenic and renal infarcts. And we did a DSA also, which had shown multiple bilateral renal artery aneurysms. So our diagnosis was revised to PEM, and we gave her IV methylprednisolone pulse for 3 days followed by oral steroids, and IV cyclophosphamide was given as monthly doses for 6 doses followed by MMF. We followed her regularly with echocardiography, and her echo had normalized by 4 to 5 months post-treatment. Coming to case 2, we had a 3.5-year-old boy with chief complaints of fever for 1 month, maculopapular rash over trunk, non-exudative conjunctivitis, cheilitis, and abdominal pain. And 2D echocardiography had revealed giant coronary aneurysms involving LCX and LMCA, and mild dilatation of LAD and RCA. On further evaluation, child also had myocardial involvement. So a diagnosis of Kawasaki disease was made, and he was given aspirin and IVIG, following which the symptoms had resolved. But 15 days later, he again presented with fever, rash, chest pain, abdominal pain, and there was persistent rise in inflammatory markers, and echo had shown a rise in coronary sizes, and cardiac angiography with cardiac CT with angiography had shown diffuse fusiform dilatation of LMCA, proximal and mid LAD, and proximal LCX with ectatic changes in RCA. So child was given, thinking that it was a refractory Kawasaki disease, he was given infliximab along with steroids, aspirin, low molecular weight heparin followed by warfarin, and following which symptoms were resolved and he was discharged. But 2 months later, he again presented with fever, blood in stools and abdominal pain, and with persistently high CRP and ESR. Upper GI endoscopy had revealed pseudoaneurysms, and so we did DSA, which had shown stenosis and bleeding in celiac trunk branches and aneurysm in the segmental renal arteries. So final diagnosis of PAN was made, and he was given IV cyclophosphamide pulses followed by MMF. So considering that this was a medium vessel vasculitis with multi-system involvement and relapsing coles on steroid tapering with characteristic DSA findings, we manage him as PAN. So the learning points from both of my cases are that not all acquired pediatric coronary disease are Kawasaki disease, and a high index of suspicion should be kept in cases not responding to IVIG steroids, especially having prolonged courses. And coronary involvement in most cases is mostly reported with Kawasaki disease, but PAN being a systemic vasculitis can also have coronary involvement, and distinction between both of them is necessary, as they both have different therapeutic and prognostic implications. Thank you.
In your second case, after 15 days again showed the rashes, fever. That was a readmission or in the same sort of
So that was a readmission. That was a readmission, sir.
Readmission.
Yes.
Say that you have to clinically differentiate between that two. What is your suggestion? How will be differentiated? And KD.
So KD, as we all know, mostly has an acute onset and symptoms are mostly acute. But PAN, being a systemic vasculitis, mostly has a chronic and insidious course. Like in both the cases, they presented mostly after 1 to 2 months of having the symptoms. Also the age, though both of our cases were toddlers, but toddlers like KD is mostly seen in toddlers, while PAN is mostly seen in after 5 years of age. Though hypertension, coming to examination, hypertension is mostly seen with PAN, but it rarely occurs with KD if we have renal artery stenosis, which is rarely reported with KD, sir. And
did you examine for the hypertension in these 2 children?
Yes, sir. Our first case had stage 1 hypertension.
That means you have not seen the pulses also.
Sir.
That's why we are stressing. Examine the person from head to foot.
Yes.
Okay, thank you.
Thanks.
That's a good case.
Thank you.
ऑडिटोरियम बंद कर देना.
And moving on from acute diagnosis, we move on to follow-up of these patients. And essentially, we have Dr. Sudha today talking to us on the cardiovascular follow-up and the role of stress test in patients with Kawasaki disease. This is one of the most important areas, especially in patients who had acute KD, and how do we follow them? Over to you, Mr. Sudha.
Mr. Chairman, and ladies and gentlemen, I great appreciate the opportunity to speak at this session. The first talk is CTA, long-term assessment for each coronary region. Japan JCS is shown. Maximum intensity projection MIP and multiplannar reconstruction MPR is a useful method. This patient is a four-year-old girl. MIP and MPR are shown. The diameter of coronary artery can be measured CTA. In the left is coronary angiogram and right is CTA imaging. We compared the diameters in CTA with those in CAGs. There was a significant correlations. Thrombus is detectable in CTA imaging. This patient had occlusion of RCA. Coronary wall thickening is also detectable. Appearance of localized stenosis without calcification is detectable. Clinical course of a 9-year-old boy with IVIG resistance is shown. He had thrombus. He had thrombus in the RCA. In this patient, CTA and MRA are shown. Thrombus in aneurysm detected, but the diameter of aneurysm decreased. Segmental stenosis was detected. In the LCA, aneurysm regressed. Sorry. CTA imaging after 1 year was shown. Cellular change coronary aneurysm are shown in this slide. The maximum diameter of coronary aneurysm at 2 months is 5.1 millimeter. In year, it is 3.7 millimeter. At 3 years and 10 years after KD, they are 3.3 millimeter and 3.7 millimeter respectively. In the same patient, CT imaging are shown. Aneurysm was regressed. In a 7-year-old boy, CAG are shown. In the same patient, CAG of RCA are shown. At 7 years old, right coronary artery was almost regressed. In the same patient, CT imaging are shown. Small calcification of both arteries are detected. The next talk is myocardial enhancement by CMR. Perfusion defect indicate myocardial ischemia, and delayed enhancement indicate myocardial infarction. Perfusion defect reflects distribution of myocardial blood flow. Perfusion defect in rest and stress is shown. This picture shows late gadolinium enhancement. Late gadolinium LGE as shown. This picture also shows LGN. Also, sorry. This picture, stress in rest and stress, perfusion defect. This picture also shows LGE in patient with segmental stenosis. This slide shows perfusion defect and LGE with segmental stenosis. This slide shows perfusion defect and LGE with shown occlusions occurred, LGE detected. This slide shows also LGE. In this patient, LGE occurred after occlusion of LAD. Subendocardial infarction was detected. This slide shows imaging of CMR and MPI. Subendocardial infarction less than 50% was found in CMR, but perfusion defect was not detected. RI spectrum MPI. The last talk is characteristic of coronary flow velocity reserve and transthoracic Doppler echocardiography in patients with a history of Kawasaki disease. Usually, the coronary flow reserve, it is unknown whether the acute inflammation caused by Kawasaki disease will have an effect on the endothelial function of coronary arteries in the future. The coronary flow velocity reserve, CFR, of the left anterior descending artery can be evaluated by transthoracic Doppler echocardiography non-invasively. Usually, the coronary flow reserve is decreased for 85% stenosis. The method, the coronary flow velocity reserve of the left anterior descending artery, examined by transthoracic Doppler echocardiography in 189 patients, male 125, female 64, with a history of Kawasaki disease and 10 volunteer control from 2005. Total cholesterol, high-density lipoprotein cholesterol, low-density cholesterol, triglycerides, fasting glucose, and hemoglobin A1C were measured at the same time. The patients were divided into 9 groups based on the LAD. Coronary artery lesion was diagnosed with selective coronary angiogram or CT angiogram that had been performed close to the time of CFR examination. Information about the patient in this study was also obtained their record. Measurement. The coronary flow velocity measurements were carried out with Sequoia mainframe with a 7.5 MHz transducer. Hyperemia was induced by infusion of adenosine triphosphate at a rate of 150 microgram per kilogram per minute. The infusion was continued until the maximal increase, about 2 to 5 minutes. During propagation, the electrocardiogram was monitored continuously, and blood pressure was recorded with a digital blood pressure monitor at rest and during hyperemia. CFR was calculated as a ratio of hyperemic to basal mean diastolic flow velocities. This patient, 17-year-old man with an aneurysm of right coronary artery. The coronary flow velocity reserve, CFR, was 2.90%. He had an aneurysm of the right coronary artery by acute Kawasaki disease at the age of 4 years. Rest and hyperemia, flow increased. The median age, time of the CFR measurement was 22 years. Based on each coronary artery region, 9 groups divided. Finding in blood sample in the respective group, there were no significant difference in the respective parameter among 10 groups. Measurement in rest and hyperemia were shown. There were no significant difference in respective parameter among 10 groups. This table shows the change of heart rate and blood pressure at rest and during hyperemia in the respective group. CFR was significantly lower, the localized stenosis more than equal to 75%, segmental stenosis and coronary artery grafting group than in the other group. Coronary artery bypass grafting does not improve the native coronary artery stenosis. The CFR after coronary artery bypass grafting may vary in each vessel in each patient with grafting. CFR was preserved in the other group, not only in patients without aneurysm in the acute phase, but also in patients with aneurysms. CFR after CABG group does not improve within normal limit. CFR after coronary artery bypass grafting may vary in each vessel of each patient with grafting, depending on their myocardial involvement. The competition native flow and graft flow after coronary artery bypass grafting is speculated. The competition native coronary artery flow can induce a string sign of the internal thoracic artery graft. Therefore, the measurement of coronary flow velocity is useful to decide for indication of CABG. We think that the cutoff value for the indication of CABG is less than 2.0, which implies significant coronary stenosis. In summary, the endothelial function in the epicoronary artery was preserved in patients with a history of Kawasaki disease and dilated coronary artery lesions. CFR of the LAD was decreased in patients with localized stenosis more than or equal to 75%, segmental stenosis, and postoperative coronary artery bypass grafting. Thank you for attention.
Is there any difference in the dimensions you measured in the LPA and MCR view? Otherwise, Professor, can you explain the MCR and the LPA you showed in the slide? Manipur, Professor, you can explain that MDA and MCR view, that the dimensions she had taken. Is it angiographic view or MRI? Initial slide showed NCR and NBI.
Another is MR based stress and imaging.
Oh.
That's the MR, if you see the images now, Madam had showed on nuclear scan, you cannot detect for endocardial. Remember, right? And that's how the beauty of MR. And in fact, given the choice, worldwide, the myocardial perfusion imaging now, the MR is the way forward. The challenge is the availability of the MR scanner. Otherwise, if you see subendocardial infarction, subendocardial defects, cannot detect on myocardial. Okay, I'm answering your question.
Yeah, same. Any more questions? Otherwise, we'll conclude. Thank you so much.
For the next session on CT angiography in KD, I would like to call on stage Professor Sujit Singh, Professor and Head Department of Pediatrics, Pediatric Allergy and Immunology Unit PGI, Dr. Tapas Subui, Professor Pediatrics, Sant Niketan Medical College, West Bengal, Dr. Manfoor Singhal,
Professor of Radio Diagnosis and Imaging, PGI Chandigarh, Professor Priyankar Pal, Professor and Head, Department of Pediatrics, ICH Kolkata.
नहीं इसी में डाल दिया ना मैंने।
अच्छा उसमें डाल दिया आपने?
हाँ उसको हटा देते हैं ना, सब इसी में ही है।
तो सुबह
तो शुरू होगा और फिर राकेश इसमें से
सबसे पहले कौन कर रहा है आपका? इसमें तो इन्होंने ये बोला हुआ है, इसी में आपका
दूसरे
वो तो मैंने इसमें डाला हुआ है।
हाँ
ये वाला ना,
ये कौन सा है? ये
नहीं, हाँ कौन सा है? आपने ही भेजा हुआ था। और कौन सा? वो इसमें हुआ।
Next speaker is Dr. Rakesh. We need to introduce Dr. Rakesh. Good afternoon. So the change of sequence. Dr. Supit Basu is going to present points of CTCA with performing cases. Dr. Supit, please.
यहाँ से कर दूँ?
आगे. Good afternoon. So, as we have been discussing throughout the sessions that so coronary artery abnormalities develops in 15 to 25% of patients with KD, and with treatment it reduces to 5%, and till date 2D echocardiography is the standard of care. But with the emergence of CT angiography, it is a very good mode of imaging modality for delineating coronary artery abnormalities, and its accuracy is comparable to the catheter coronary angiography, which is thought to be the gold standard. So what are the advantages of CTCA? It is non-invasive, can be easily performed during the acute phase once the patient has stabilized, and can be repeated on follow-up. The ability to visualize the coronary arteries and their branches over the entire length with little or no inter-observer variability is a distinct advantage over echocardiography. And also CT angio provides the temporal change of coronary artery lesions, that is resolution, persistence and remodeling, and also accurately delineate the luminal changes, that is stenosis, steno-occlusive lesions, thrombus and mural abnormalities like calcification, which can develop over years. Here in this image we can well appreciate the full length of the RCA, that is a proximal and mid aneurysm. Here we can see a filling defect suggestive of thrombus, the LAD which is dilated with the branching of the LAD. Here we can see the RCA. If we do, this is the mid portion, which is fusiformly dilated, and here we can see this white thing, there is a calcification in the left anterior descending artery. So what the studies suggest? There is a study conducted by Manful sir et al., where they suggested that CTCA demonstrates the distal segments of the coronary artery aneurysms better, which cannot be or mostly missed in the 2D echocardiography. And in this study, it was suggested that when to do CTCA, they have suggested an algorithm. The children with Kawasaki disease at presentation, we should do a 2D echocardiography. If coronary artery abnormalities are absent, then CTCA is not required. If coronary artery abnormalities are present, then we have to go do a CTCA. Then we have to see whether it is distal aneurysms are present or not. If there is distal aneurysms, then we should consider CTCA on follow-up, because on follow-up also by 2D echocardiography we cannot assess the distal aneurysms. But if the distal coronary artery aneurysms are absent, then TTE or 2D echography may be sufficient for assessment of coronary artery dimensions. However, CTCA may still be required for the evaluation of mural changes, mural calcification, stenosis and thrombosis. This is a recent paper in Lancet for the assessment of left circumflex artery, and here they have said that the CTCA is the preferred imaging modality for left circumflex in Kawasaki disease. And abnormalities in left circumflex are seen in 18.2% of children with Kawasaki disease on CTCA, and most of these, around 63%, were missed on 2D echocardiography. Now when we studied the different guidelines that has been published, the American Heart Association guidelines, the Japanese Society guidelines and the Italian Society of Pediatric guidelines, the indication of coronary angiography in Kawasaki disease. So the indications is mainly from the I will come to a 2024 later. So it is the HA 2017 guidelines which recommends the use of CTCA during follow-up when echocardiography becomes limiting because of the poor acoustic window as the child grows. And the Japanese Society has also suggested CTCA for the changes in the follow-up period, both Italian Society and Japanese Society. And in the acute phase in 2017, they said there was one line that CTCA can be of value in the assessment of selected patients but are not routinely indicated. And the same thing, the older children. And when to do CTCA? So almost both the guidelines, the Japanese Society and the American Heart Association is almost the same, that they are considering on follow-up. In Japanese Society guidelines, there is a first in the convalescent phase you should consider, then 1 year from onset and every 3 to 5 years. Whereas in case of HA 2017, it is every 2 to 5 yearly, and the indication in follow-up is almost same. to look for the thrombosis, stenosis and the mural abnormalities. And the calcium scoring that has been recommended in both the Japanese guidelines and the AHA 2017 guidelines. Now coming to the 2024 statement that has been published recently. So what are the changes? So the first line they have written that for the proximal aneurysms, both the CTCA and the echocardiography correlates well, but CTCA is superior for detecting distal aneurysms. And the study that they have quoted is the publication from Manful sir in the Oxford. And next is the long-term surveillance with CTCA is essential in patients with persistent aneurysms, particularly for detecting calcification, assessing stenosis, progression and confirming thrombus formation. The new point that they have added that during the acute phase, so CTCA is particularly useful at hospital discharge, so during the acute phase for giant aneurysms. And CTCA is helpful at 1 year from diagnosis. For the rest of the aneurysms, when they have proposed the CTCA should be done at 1 year from diagnosis as a baseline and then every 2 to 5 yearly to monitor long-term complications. So to conclude, so what are the proposed indications for CTCA? So in the acute stage, for older children and adolescents where there is poor acoustic window, children with doubtful or equivocal echocardiography studies, children with a severe disease course in the acute stage like KD shock syndrome, macrophage activation syndrome or symptomatic myocarditis, or any infants aged less than 6 months because they are high risk of development of aneurysm. And in the follow-up, to document the resolution or progression of aneurysms, to monitor the distal aneurysms as this cannot be evaluated by echocardiography, long-term surveillance for the detection of mural abnormalities and to delineation of thrombosis, stenosis and dystrophic calcification. Thank you.
The Pgimer and others, it has not mentioned. So, thank you. Discuss later.
एक्चुअली आपका ऑफिस 365 में है.
So Priya has already told us when it should be done. Now Rakesh is here to tell us why it should be done. So what is the indication why it should be done?
So basically role is reversed, but because I have to start with why CTCA is required and then the indications Supreet has already told. So next 10 minutes I'll just be able, I'll try to convince you that why we are talking and why this 1 hour session is for CT coronary angiography in a Kawasaki disease. So I'll start with the case because that will make more memories, because this case came from from Guwahati, and fever, maculopapular rash, redness of eyes and swelling around the left side of neck. Then fever was persisted in next week also, and then developed progressive generalized swelling with gradually worsening respiratory distress and admitted to another hospital. And he had developed hemorrhagic pericardial effusion, required mechanical ventilation, and at that time MIS-C was also a possibility, so COVID antibodies were done. But then echocardiography was done at 10 weeks. So at that time there was giant aneurysms and query thrombus was there. So when we had done echocardiography, there was giant aneurysms and thrombus was there, and these were the giant aneurysm in RCA, LED. But what we can't see is that the extent of the aneurysms in the distal part and what are the severity beyond that. When we did CT coronary angiography at our hospital, which you can see is that these are the very horrible left circumflex, which we can't even see in that. There is hugely dilated LCX, and it's like an aneurysmal in the distal extents also. LED, the aneurysm, there is one more aneurysm which is almost in contiguous of that. So there are multiple aneurysm to have. So echo basically underestimate but echo has given a fair idea that there are several issues, but still but the true burden of the disease has not been picked on that echocardiography. So we all know that cardiovascular complications are the most important life-limiting or morbidity causing complication in Kawasaki disease, and these are coronary artery aneurysms, and if you don't treat that, 25% of patients will be at burden of this disease. So CAs of KDs are that coronary artery abnormalities can be form of aneurysms, ectasia, dilatation, stenosis, thrombosis. It can involve any segment of coronary artery that is a problem, although it's more of proximal, but distal segments are also. And the precise identification is most important part, because that will be the for the treatment stratification and severity and prognostication also. So echo is no doubt that is generally the preferred imaging, but however echo is not enough, which I have shown you, and there is no unanimity on ideal imaging modality for long-term follow-up. That is a problem. So what we have in our imaging armamentarium is that echo, coronary, that conventional cath angiography, and MRCA and CTCA. So why we are talking of CTCA is that echo is the standard of care, but we can't see middle and distal segments. The complications and thrombus and stenosis are difficult to see, and it's operator dependent, and we although we can do more and frequently, but still these are the issue. Then the cath angio is gold standard, still remains a gold standard, but it's an invasive inordinate radiation exposure and cannot be repeated often because you can't do many times. MRCA is definitely a imaging of choice if you can do like whatever you want to do, but that the problem is that long acquisition times, and in small children you can't perform that, and its temporal and spatial resolutions are. So therefore we have a CT coronary angiography, and CTC is a non-invasive, and in the current standard high resolution CT scanners, which we can also control the radiation exposure also, and what we have shown is that radiation exposure is within acceptable limit, that is less than 1 millisieverts, and if you can compare an X-ray chest is almost 0.1 millisieverts and is almost a 10 X-ray, so which is not very high, but because in children we are more concerned with radiation exposure, and there is an excellent correlation with measurement on echo and angiography. You must have seen Dr. Suda has just shown in previous talk that how she has compared with the CAG and CT angiography diameters, and which is almost comparable. So CTC has a potential to become the standard of care for diagnostic evaluation and CA in children where it's applicable. So what we have seen is that over the years we have seen that coronary artery abnormalities in prevalence has increased in our cohort. So in 1994 to 2004 it was around 5%, but it has risen to around 16%, and there are several reasons for that. Possibly we other part of the India has also seen, because Professor Pgimer Paul has also seen that the coronary artery abnormalities prevalence in their cohort is also. But one of the factor is that the increase imaging modalities, because echo we can do more frequently nowadays, and then CT coronary angiography has also changed our the way we are treating and we are managing these patients. We can identify more and more aneurysms in these patients, and you can see then follow-up also. So it's an amazing paradigm in the Kawasaki disease, and it's thanks to the Professor Singhal, because of him we can do these CT coronary angiography, and the one more important part is that whenever we are doing CT coronary angiography, the radiologist should be there, because and he will be there at each and every CT scan. Because you have to optimize radiation, you have, like in children we can't compromise about the radiation exposure. So the CT coronary angiography is the way forward, and what we have shown in our experience also, that distal coronary angiographies distal CAs are there. It may be that they are in isolation also sometimes, and if you don't do CT coronary angiography, you will completely missing these patients. And in one study what we have seen is that, because it's always a concerns that whenever we don't treat Kawasaki disease, that is a spontaneous defervescence, what happens to them in a long run. So echocardiography is the good, but what we have done is that after mean follow-up of 3.8 years in children with Kawasaki disease, we performed CT coronary angiography and there was no coronary artery abnormalities and even calcification was not there. So that is a reassuring also that if whatever we are doing in a clinical science in KD with spontaneous deaffervescence, which we have almost 5 to 10% of children, we may not be able to treat because they are coming late or possibly it's a milder form of disease or when they are reaching that already they are in deaffervescence. So if there is no coronary artery abnormalities on echocardiogram and the inflammatory markers are normal, possibly we are much comfortable now that based on these findings that possibly we are doing right. So this paper has already been shown by Supreet that this is in a proposed algorithm as distal as per the requirement, and then why we require a CT coronary angiography is because of this also, possibly because left circumflex is hardly we can see, and we had a 1 hour session today in hands-on also, and everybody was convinced that it's difficult to see LCX and because of several reasons, and so 2D echo is inadequate in identifying LCX. And why? Like because although it's a left circumflex is not so frequently involved, but sometimes it can be involved in the isolation also, and at that time, because if you don't pick these coronary artery aneurysms, possibly you will miss them and you will be able to stop the aspirin, but here if there is a coronary artery abnormalities in LCX, you have to continue these patients on aspirin. We can do calcium scoring also in follow-up, and the study from the GIAN group has suggested that most patients will develop calcification after 10 years, but recently we have shown that it can develop very early in the within 1 year also. So, but if the patient has not developed calcification after 10 years, possibly you are comfortable in saying that possibly they may not develop after 10 years. It's required in a mandate follow-up also, because you may see the remodeling of these and in remodeling of the coronary artery aneurysm. So to summarize, it's a non-invasive and daycare procedure, because we can perform whenever a child who is like whenever it comes to a daycare in morning at 9 a.m. and we perform the procedure by 11 a.m. and he will go with a report at 12 p.m. and cuts to Professor one full single. It's a luxury that we can have in 4 hours a procedure with a report in hand. So that can be done, and it's a superior imaging of entire coronary arteries, including distal segment and left circumflex, and it detects mural abnormalities also, thrombosis, stenosis, and calcification, which are missed. And the radiation exposure we have been able to optimize. What we can see is that infants, the radiation exposure is almost less than 0.5 millisieverts in most of the infants, and in older children it's around 1 millisieverts, which is also acceptable, and it can be useful for acute, convalescent, and long-term monitoring, and it's increasingly becoming the preferred imaging modality. And we have seen in latest update of 2024 American Heart Association, and they are also comfortable in saying that CT coronary angiography is possibly a way forward in evaluating the coronary artery abnormalities in children with KD, and it reduces the need for invasive CCA, which is very important, because if you like nowadays the indication for catheter coronary angiography is that when you want to do anything, you want to operate or you want to intervene, then only go for a catheter angiography. Otherwise, you just do a CTCA. Based on that, if there is a stenotic lesions or not, that go for a perfusion imaging, and then if there is you want to intervene, then only go for a catheter angiography. Thank you.
Thank you, Rakesh. So we have discussed when to do it, and now we'll go how to do it. So we have covered all the 3 aspects. Now we are going to discuss how it is to be done. So with this, I invite Dr. Shrishti Sharma. She is an assistant professor at AIMS Patna, and my dear friend and colleague Dr. Arun Sharma, who is an associate professor. So we have divided this into 2 parts. So one will be, how to, why you want to do it. So we will discuss this. So to begin with, I invite Dr. Shrishti to begin with.
किस नाम से है?
खुला हुआ बच्चे का खुला हुआ मैं खोल देता
चल रहा है सर, चलाया
इसको निकाल दो।
नहीं चल रहा है, उधर रखिए, चल रहा है सर, उसके नहीं चलाया।
नहीं खुला हुआ है यार यहाँ पे।
दोबारा खोल दीजिए, दोबारा खोल दीजिए, कोई चक्कर नहीं। दोबारा खोल दीजिए।
अरुण इसमें मेरे पास 2 सॉफ्टवेयर हैं, इसको नहीं रहा है। एक मिनट चल रहा है यार, इसको निकालता हूँ। यही है ना रखे, यही है ना, चलो के देखिए, यही है ना, यही है, ठीक है।
स्लाइड शो, स्लाइड शो, स्लाइड शो।
स्किप तो नहीं कर रहा। हाँ हो जाएगा, मुझे लगता है।
एलईडी अटका, इसमें लेट आएगा, एलईडी में
हाँ आ गया।
स्लाइड शो की,
स्लाइड शो
दोबारा की,
दोबारा करूँगा। ठीक है।
पॉइंटर नेक्स्ट इज
नेक्स्ट
नेक्स्ट इज विल हैव टू से पॉइंटर
नेक्स्ट किसी Good afternoon, everyone. I am Dr. Srishti. I am an assistant professor in the Department of Radiology at AIIMS Patna. And we have recently started doing coronary CTs in the pediatric age group with the guidance from Manful sir. And I'm very thankful to sir for being available there and helping us develop protocols for the same. So why is cardiac CT and how is cardiac CT different from CT that we perform for other organs like the liver or the lungs? So the main difference is that if we want to perform a CT of the liver, we just ask the patient to hold his breath and we can take an image of the liver. For brain, we just ask the patient to not move and we can take the image of the brain. But for heart is a continuously moving structure. So it's like taking an image of a person who is running. And so it is prone to a number of artifacts. So to tackle this problem, what we do is that we perform cardiac CTs with ECG gating. Right? So, as we know, high quality source images are very, very important for diagnostic assessment of coronary arteries, which are very small structures. And as mentioned earlier, because of the moving nature of the heart, it is done with ECG gating, but the downside of ECG gating is that it increases the radiation exposure that is involved. And so proper protocol making and radiation optimization is extremely important when performing cardiac CT, more so in the pediatric age group. So we just have, we cannot perform, because of the radiation exposure involved, we cannot perform the scan again and again, and we just have to get it right in one single time. So the things that we'll be discussing in this talk would be patient preparation, contrast injection protocols, data acquisition, and radiation optimization methods. So as we know, CT was the first CT scanning system was developed in 1972, but cardiac CT could not be performed as late as 2004. And in children, it could only be performed after the discovery of dual source CT scanners. So why was this? So what does a 64 slice CT scanner mean? So suppose the craniocaudal dimension of the heart is 14 centimeter. In a 64 slice CT scan, with one rotation, suppose the machine covers 4 centimeter of the heart and the craniocaudal dimension of the heart is 14 centimeter. So the CT machine needs at least 4 rotations to cover the whole heart. Now, as the number of rotations increases, the scan time increases, and with that, the radiation dose also increases. So, from 164 slice CT, when we moved on to 128 slice CT, the CT machine could cover the whole heart in two rotations. So the scan time was further reduced. And now with dual source CT scanners, we are able to cover larger volumes of the heart even with a dual source CT scanner means that there are two X-ray sources which both cover some part of the heart, and so we are able to cover more volume of the heart in a single rotation, and so the scan time has been significantly reduced as we'll see later. So as it started, we started with a 4-row multi-detector CT, to 16-row, to 64-row multi-detector CT, and now a 128-row multi-detector CT. And as we increased, the scan duration significantly reduced with time. So with 4 slice, with a dual source CT scanner, the scan time is less than 1 second. So as we see with a 64 slice multi-detector CT scanner, the scan time was almost 27 seconds. And with a 27 second scan time means that we'll ask the patient to hold breath for almost 27 seconds, which is difficult even for adult patients. For pediatric patients, it will be even more difficult. But now with dual source CT scanner, especially the flash machine that sir has here and we also have in our institute, we have been able to reduce the scan duration to less than a quarter of the second. So now we can perform these scans even in pediatric age group, and the radiation dose, as we can see, has been reduced from 1598 in milligray centimeter to 211.9 milligray centimeter, which means less than 1 millisievert. So we are able to get images with very good spatial resolution, temporal resolution, and within the radiation limit that has been prescribed by various societies. So in a dual source CT scanner, what happens is that there are two sources of CT scan which both cover half of the volume of the heart, and so even in very less time we are able to cover the entire volume of the heart. And so to perform a coronary CT, particularly in pediatric age group within the prescribed radiation limits, it is not only important that the protocols are right, it is also important that we have the right hardware of the machine, like this dual source CT scanner. So in which a large area is covered per gantry rotation. So this allows, so what happens is that as we know in coronary CT, the prerequisite, we often give beta blockers to control the heart rate. So why is this important? So usually it is said that the heart rate should be less than 60 to get a good image in adult patients. Why? Because cardiac CT is done with ECG gating. So what ECG gating does is that we try to image the heart in the phase of the cardiac cycle in which there is least motion. And this phase of the cardiac cycle is usually the RR interval. As we reduce the heart rate, the RR interval increases, and that is why we get more time to cover the heart in that in the time of the cardiac cycle in which the motion of the heart is least. But with dual source CT scanner, even with high heart rates, we are able to image coronary arteries with very good spatial resolution. It also allows motion-free images of exceptional quality because we have been able to reduce the scan time to less than a second. Breath hold is also not a problem in performing these CTs, and feasibility for radiation limitation to the prescribed levels of less than 1 millisievert. So to perform a successful CTCA, which allows us to image coronaries and get good images for adequate interpretation, first we have to know the indications why the scan is being performed, because radiation exposure is involved, so the scan must be justified. We must have the KFTs of the patient renal function test report because of an of contrast-induced nephropathy which can occur. Next is patient preparation, peripherals. All this will be discussed in the later sections. But as we discussed earlier, beta blockers are given usually to the patient not only to control the heart rate but also to prevent any arrhythmia that occurs during the performance of the CT scan, ECG electrodes. And finally, we perform the acquisition of the image and the interpretation. So the next part of the talk, Arun sir will be taking over.
With this, we have known what is about CTCA and how the hardware and software has changed in the last 2 decades that has enabled us to make the coronary arteries, which is a moving organ in a moving cage. this, we need to know how the data is required. So as a radiologist, we are fortunate that we have a good support from the pediatric allergy immunology unit. So we have a dedicated WhatsApp group, and usually when the patient is decided that you need to go to the CTC, they will contact me or Dr. Arun whether we are available. If we are available, we'll tell them at this time you need to come. Patient comes to the daycare or admitted, whatever the scenario is, and patient comes to the team full resuscitation kit. And believe me, it is so, anybody, any corner of India can contact us, and I can assure you, you will have a flawless experience which you never have thought of it. And thank you, Professor Sujit Singh and Dr. Rakesh and his team, that they have created this model. And this model has not come in days, it has taken years to come to this stage. I request the young, the DM students have come to respect that protocol that we have made and try to duplicate when you go back to your respective places. So once the child is in, depending on the age of the child, requires sedation or without sedation, we train their parents, we train their patients, and then that's how to get food images. So to cover these aspects and how we do it, I request Dr. Arun to go forward and let us know, what is our protocol and how we do it.
Thank you, sir. Thank you, Dr. Shrestha, for covering the initial part. So coming on to the data acquisition or the day of acquisition of the scan. So as for any other CT, the consent from the parents of the child is taken, and we have to see for IV access. So the preferable intravenous peripheral venous access is preferred, preferably in the right arm. However, any access these days, whatever access is given, we can perform the CT, but we have to change few parameters. But it is always better if it is close to the heart. Why? Because in that way, from the peripheral venous system, we mitigate the dead space till the volume of the contrast reaches the aorta and it opacifies the coronaries. However, in small kids, it's difficult for access. So any access these days with the recent machines, scan can be performed with some changes in the parameters. What type of cannula? Because the volume and the rate depends on it. So the larger cannula is better because we need to give more flow rate, and a rough idea is the 24 gauge cannula or 26, but then the maximum flow rate, whatever it permits for better acquisition, is we don't have to exceed it 1.5 ml per second, and in generally these small kids 0.5, 0.7 to around 1 or 1.2 is sufficient for acquiring an optimal CT scan. Then the placement of the ECG leads, but then the patient we need to see for then we take the patient for positioning. Patient is, these CT is acquired with the patient position supine and with the sedation. The technician also, we also have straps to strap the child so that there may not be during the injection, or if there is inadequate sedation or patient fall, it avoids. So we have, please. Okay. And then ECG electrodes are placed when the patient is positioned, and we have to check for intravenous peripheral venous access, and technician, the role of technician here is to check for its patency, while always a fresh cannula, and to see for continuous flow with minimal amount of saline, to see that there may not be any extravasation during the scan, which is rather worse for the small kids. So the scanning it involves various phases. For first is topogram. Topogram just to select the acquisition from which level to distally up to the length of the scan. Then non-contrast calcium scan, the indication have already been told by the previous speakers. So it is done in the chronic phase or in the follow-up, not in the acute phase. And then the angiographic acquisition with different modes, as we will discuss it later, prospective or retrospective, with their advantages, and then interpretation of the scan. Scan interpretation, the particular importance is of curved reformation and volume rendered images, which shows the scan in full length of the coronaries, even on one image of the CT. So we can just see for the calcium score, which there is automated software, and it provides the values just at a glance by the color coding system for different coronaries, and anybody can see it with the different color perspective and what is the calcium score. So coming on to the acquisition is done with the as initially told, first the topogram, then the contrast medium protocol optimization, followed by coronary CT angiography. So we start. So the positioning is very important, because if we limit the z-axis, the coverage total from cranial to caudal, only that will relate to the optimal radiation exposure. If unnecessary we cover the larger portion of the body, the radiation will be exponentially high. So we just begin above the carina, and we have to, because to cover the coronary origin, which is well below it, and the ending position is just below the diaphragm, as we can see here. So it is just below the carina to below the diaphragm, to include the that we see all the coronaries. Just below the diaphragm is to see for the distal extent. We may not miss those, and sometimes the kids may move slightly during the examination. That is the main reason we sedate it. So then we have to see for the contrast medium. Contrast medium is that the contrast delivery should be timed in such a manner that we acquire in the acute, in the full aortic enhancement phase. At that phase, the coronaries will be opacified clearly with the uniform opacification, and a saline bolus is given to clear the contrast from the right side of the heart and SVC, because otherwise that will cause artifacts and you will not be able to see those coronaries which are in that direction, particularly the RCA, proximal or mid RCA. So this peak aortic enhancement concept it is approximately the gamma variate bolus geometry. We will see that there is inherent delay, as the contrast is in the peripheral venous system, largely unmixed over the contrast injection duration, but it has to reach up to the left cardiac chambers for proper mixing and proper opacification of the aorta, which will give us the better visualization of the coronaries. So as we can see this, if we see the time density curve, it has a inherent delay. That delay amounts to the inherent scan delay, particularly, and followed by the peak enhancement and the temporal window for acquisition. So this temporal window, we have to acquire the CT during this period only. This window can be broadened or can be narrowed depending upon the protocol, how fast we acquire, how slowly the injections are made, or how fast the scan is taken. And this window is proportional to the volume of contrast injected and the bolus injection time. So if they increases, then it can further be increased, which will result in faster, earlier recirculation and poor opacification of the contrast. So optimal opacification during this window is very important. Then the iodine concentration. As these parameters are highly dependent for obtaining an optimal CT acquisition. So the iodine medium concentration, higher iodine medium concentration correlates well to the higher opacification and the volume and rate of contrast administration and timing of the contrast medium delivery. So the volume of contrast can be calculated by estimating this scan delay, scan time, inherent delay 5 seconds for this current scanner, and the flow rate. Flow rate, it depends on the cannula size. then we can use either contrast bolus technique or the test bolus technique. Here we place the region of interest in the ascending aorta for evaluating the coronaries, and with the bolus we can see its opacification, fix a target of 100 or 120 HU when the opacification of ascending aorta is maximum. At that phase will correspond to the maximum opacification of the coronary arteries. At that time the machine triggers the scan. So we have two modes. It is the prospective gating mode or the retrospective gating mode. In the prospective one, we can see that it is a step and shoot method, and the scanner, it is scanning only during the prescribed period of the RR interval. And so the advantage is it is having a lower radiation exposure, but it requires a stable heart rate. Lower and stable in adults, but at least stable heart rate in kids. Contrary to retrospective gating, which is, if we see, it is a continuous acquisition throughout in the helical mode. And however, so as it is a continuous exposure, it will cause increased radiation dose. Then how to optimize radiation exposure, as we were discussing, because this is the most important aspect, which is limiting the full implementation of this coronary CT angiography in kids, which is the gold standard for adult population. So we have several methods these days to reduce the radiation exposure to sub-millisievert scans. Even half of millisievert is possible with current generation scanner. First is, the most important is reduce the length of the scan, craniocaudal extent of the scan only for the whatever is required. Then limit the FOV. We do ECG dependent tube current modulation. We perform with the current modulation that there is continuous tube current is going on during the whole of the cardiac cycle, but the maximum is during the diastole. And then we decrease the kV, the voltage and the tube current. Nowadays the machines are intelligent enough to have the care dose and care volume voltage setting, which are automatically set as per the patient body weight. And so otherwise in kids we usually do it with the 80 kV. Even we can see even the 20 kV reduction will result in nearly half of the radiation burden. And we do prospective ECG triggering with adaptive sequence. And even latest generation scanners, we have a high pitch helical mode which is very fast and can within one heartbeat can scan fully with sub-millisievert radiation dose. Finally, the reconstruction algorithm using latest iterative image reconstruction method, it results in substantial radiation dose exposure to the kids. So here we see the full tube current. If we see, as I have discussed, that ECG tube current modulation is that it is not going equally all along the cycle. It is high during the diastolic phase and lower during the systole. So it effectively reduces the radiation from 20 to 48% without compromising the image quality, as well as the reconstruction method, which is already incorporated in the software-based systems. And nowadays these systems, they use only iterative reconstruction methods, because the earlier one uses higher tube current, which then quantifies for the higher radiation exposure. So the take-home messages are that CT angiography is the rewarding once it is done appropriately, and in-depth knowledge of scanning technique and anatomy is important. And always customize your scan with proper radiation optimization to have a least radiation optimal CT scan imaging. Thank you.
Longterm, for giving us the insights of CT coronary angiogram, how it is to be done, and though the forum is, I think the topic was chosen at least to introduce what is possible, what is available, and how it can be used in routine clinical practice. I would like to make two comments that once you want to do it, first is intent. If you want to do it, definitely it can be done, and I thank Dr. Shrishti that they have taken a lead, and recently they have acquired one case, and I think it has come up very well. So once you want to start with, you can start with congenital heart diseases, and then slowly you can come to the Kawasaki disease, which is not very difficult. It is a matter of time, and definitely there is a learning curve to anything. I think it is our intent and it's our heartfelt wish that we have good spots of coronary artery imaging all over the India, and we are committed for that. Anybody who is here or otherwise your friends, you kindly connect to us and we will help them the way we can. In fact, we can go to their sites and firstly visit them and gather their protocols. If there are any questions, kindly let us know. We will be more than happy to answer. And Shrishti, can you join here? Dr. Rakesh and Dr. Sukhdeep, please. I think we should have some discussions on this topic.
Before they asking question, I can just start because sedation is always a issue in young children, and how we are dealing here in sedation is that mostly in children above 5 years of age do not require sedation most of the time, and children below 5 in CTCA we use sedation is triclophos, like this pedicloryl followed by midazolam. So most of the children are like out of 90-95% children will just require a triclophos and one dose of midazolam, and but sometimes that they require a repeated dose of midazolam. So, and the sedation is only for 30 minutes, and they can go home on the same day, like within an hour, a child is fine. So, in our experience, we have performed more than 300 patient CTCA. Possibly now it's touching 325. But we have not used general anesthesia in any of the patients. So that is a very important part, because we can, this is a daycare procedure for us.
Any of the patients, irrespective of the age of the children having Kawasaki disease. So their teams does a wonderful job, and the important thing is CT coronary angiogram. For that matter, action time is in maybe 1 or 2 seconds, and all the procedure is over within on the table to once the patient comes on the table and goes back. I think it's not more than 10 minutes. And our technicians are also very well trained, and they are happy doing the Kawasaki disease. And I would like to advise what Dr. Shrishti has mentioned is, if you want to embrace cardiac imaging, if you want to embrace coronary imaging, and day before yesterday I was in Delhi, I always re-emphasize this point. Please be on site. Don't be dependent on the technical stuff. There are small things that you can pick up and make a difference. Positioning of cannula, patency of cannula, size of cannula, how much of contrast volume you want to use, how much of flow rate that you want to use, everything is important. As Dr. Arun has also mentioned, when the kid comes to us, we always ask 2-3 things. One of you probably asked me, sir, why you ask all these questions probably at the end of his residency? Because this is helpful in knowing me, what is the size, I calculate the volume, dosage, and so forth. These things are very, very important. Just for imaging,
because you were telling about that 1 second time only. For that 1 second, we have to prepare for that 1 second. We have a performer, complete performer. This is like start from day minus to day 0 to day. So that performer has to be followed in a sprint actually. So because that is a very important part, because what we are preparing for that 1 second is that preparation is very important. So we instruct the patient in clear words and then nip or oral and followed by that what contrast cannula, which cannula, size of cannula has to be checked, and then we give beta blocker possibly. Professor Singh will also highlight that why we are giving beta blocker, because we need a stable heart rate, and he always says that I need a stable heart rate, I don't need a bradycardia, low heart rate. Because in adults they say that it should be around 60, but in children we can't come to the 60. So if we will try to come to 60, then it's difficult. So most of the children will heart rate would be around 100 to 120, and if you are doing any procedure possibly that at that time so even we are doing heart rate of around 120, the imaging quality of images are like wonderful. But the most important is that preparation for that 1 second is very important. So everything should be in a written, protocol should be followed, consent, then contrast, cannula, then we give 1 hour before beta blocker, which we use as a metoprolol, so which provides a stable heart rate in the children. So that is important, because preparation is the most significant, and then monitoring, post-procedure monitoring is also equally important, because we don't know that which child will behave differently to the sedation, because it's midazolam is giving a sedation is always a difficult task. So whenever we are giving sedation to them, so post-procedure monitoring is also very equally important. So that we put a monitoring seat in that protocol only, and our 2 senior residents go with the patient for procedure and 1 junior resident. So that team is important, because of that only possibly you can do procedure and without any complications and any consequences.
Procedure also the air temperature.
Yeah. Yes.
And also small amount of beta blocker will happen.
Yes.
And you have mentioned the dose of 10 times of X-ray. The dose of one ml. Yeah. Is it with the 120 slice or sustain, or does it matter the slices radiation?
Yes, it matters. Now with the use of higher generation scanners, it is even less than 1 ml. Slices don't matter, as Shifty was saying, lesser number of detectors, more every rotation that you need to cover that area. More the times rotates, more the time the radiation. That is why when 64 MDCT came into clinical practice, never when 2000, I remember those days. In the beginning of 2013, somehow I don't know from where the idea came. That I cannot answer. I went to Professor Singh. He said, why don't we use ETC in KD? He used to ask me radiation at that time. I never thought of radiation. Why he is asking me radiation? Every day I used to come, you read and come 15 days. How you have to do that? I had no answer. Then I used to read. I used to ask Siemens guys. Then Siemens guy used to tell me, they told me later on, these are the questions that are very difficult to clear, and we are able to find those answers. And slowly we began our journey.
The study also, did it matter with us, right? The 128.
Yes, sir, that's what I pointed that
How much time duration in 128 study?
That's what I'm coming to it, sir. So once we had that scanner, we have a definition that the second generation use scanner. So more is the detectors, it means more is the area coverage. Say for example, the detector which is 0.5 mm, and if a detector is 400, you can cover 20 centimeters. 400 into 0.5 makes is 20 centimeters. So you can cover whole of the heart in one heartbeat. That's it. You need not to have a large threshold, and you can complete your heart in single beat. Less of the rotation, less of the radiation. And beta blockers, Rakesh, can I ask you how much of metoprolol you give, because Dr. Arun was asking me. And how you give it?
It's 2 milligrams per kg.
It's 2 milligrams per kg, and you give oral metoprolol. Oral metoprolol in my experience is good, and half-life is only 2 to 4 hours, so it is a very safe drug in that sense. In our experience, it has not created much of problem. So I request Professor Sujit Singh, how when we shifted from our main hospital to this new machine, he used to be after me and Rakesh, why don't you have performa in this thing? So sir has, made that performa. Sir, I would like to have congratulations. And how it was a game changer.
So basically that because we have evolved over the years, in the last 9 years, it's more than 9 years, I think it's 11 and a half years. So but initially the CT scans, that there was a lot of difficulties in doing all these things, a lot of fear was also there, how to do, and so, but gradually what we have evolved over the time is that we have performed, formulated our protocols, and in last, I think from last 4 years or 4.5 years, we have written protocols which we have devised through our multiple round of discussion with unit consultants and senior residents. So how should we do, and that protocols and checklists are always there, because human can do mistakes, but if there is a checklist, you have to check on all the things, and that is a very important, because one has to go into the protocol and see the ABCD, and checklist should be completely done. Then only we can because it can be any bad day or any day can be bad also. So therefore written protocols and protocols should be followed ceremoniously rather. So therefore it's important, and we have devised our protocol in the form that day minus what we have to do, what to explain the parents the day they are coming, and the day 0 that is the day of the procedure. So one morning where should they reach, and how fasting and all these things which I have already alluded previously. So possibly this is a very important component. And the second thing is that which is possibly important, which is highlighted by Dr. Singhal also, because the radiologist should be there at that time, because he knows that how to can optimize the radiation and everything, because that is a very important component. And I can't even remember a single CTCA where Dr. Singhal was not there around actually to supervise all these things. So possibly that is the essence of the CTCA, because one has to present and one has to coordinate everything, and if there is a team then possibly that because it's an elective procedure, and in elective procedure you are giving a sedation, and possibly for elective procedures giving a sedation, and then at that time the coordination should be very smooth. And it's why we are talking CTCA, because it has changed the treatment in several of the patients, where we have had doubtful aneurysms in older children because of the acoustic window, which was difficult to go. Then CTCA has helped us or reassured us that whatever we are doing is fine, but there is no such aneurysm, or possibly that aneurysm extent has also been identified. And I can distinctly remember one patient where we had treated, and then the initial echo was completely normal, but when because child had a refractory disease, IVIG refractoriness, so we have to give infliximab, steroids, and one fine day on Thursday rounds, so these things are told that why don't you go for a CTCA, because this child is a very difficult child too. And then when we did CTCA, there was a distal RCA aneurysm, which was difficult to pick at that time. So possibly it's a game changer sometimes, and that's why we have proposed also recently, we have published in archives that at what time we can consider the CTCA in children with KD. So possibly the difficult disease, severe disease, and when there is IVIG refractoriness, and even if echo is normal, possibly there is some role of CTCA in those patients also at one CTCA, because that will reassure or that will change your way you will treat that patient.
You mentioned about to do the procedure and all the procedure. So in that you showed that the area of interest from cardiac to that traumatic area. But nowadays we want to send for the, we want to know the systemic involvement of the arteries also. So will you scan first at a glance very quickly and then you concentrate that particular? Because you want to know relative what happens in India, axilla. So that's the main important thing. From the echo we can see what is coronary. Definitely CTCA will help. So will you do that part also for us?
No, that is, it will be done only as per indication because that will impart the radiation. So first is the coronary system. We are doing it targeted for the coronary, but if we want to do for others, then we have to devise a separate protocol using the, on this scanner, latest protocol high pitch scan, which has a substantially reduced radiation. That protocol can be combined with it, but only if there is high clinical suspicion, not routine. Because if we try to do it in routine, then radiation will increase.
So this has highlighted very important point, because when giant aneurysms are there, the chances of peripheral aneurysms are also there. So few guidance has suggested that you can do a survey scan of peripheral coronary or peripheral arteries also, systemic arteries also. So which possibly it's not in guidelines yet, but few if I can remember, Professor Jane Burns has also suggested that you can do sometimes when there are multiple giant aneurysms, because chances of systemic artery aneurysms are also there. So survey scans can be done in these cases.
We have very much invested. If you have any for a CTCA, why not we want to all look for the other vessels also?
So the other vessels do not require ECG gating. So ECG gating imparts more radiation. Evaluation of the other arteries do not require ECG gating, and ECG gating imparts more dose. So if we increase the field of view to cover the other vessels, it will impart unnecessary radiation. So a separate protocol needs to be made for those patients in which those arteries can be covered but without the ECG gating, so that unnecessary radiation is not.
What I do advise is once you do an echocardiogram, better do an ultrasound, grayscale ultrasound to see at least the major vessels. You can very well see the carotids, you can see the subclavian arteries, axillary arteries, abdominal aorta. And if there is slightly suspicion, you can always refer to us. There is suspicion of aneurysm, and that's how we modify it. I know one patient had swellings, and we did publish that also. There was multiple systemic aneurysms. It is just until unless you suspect it, or you do some non-ionizing radiation like color Doppler or ultrasound, I think it should not be a matter of routine. As of now, I don't know how the things are going to change in the days to come. And I just want to tell about protocol. The protocols are sacred and sacrosanct and non-negotiable. All the protocols, once done, have to put in the WhatsApp group, and they are checked. In fact, sometimes Professor Sujit Singh will ask me when I go for something else to see the registration kit check ki thi, and Professor Mehta ne ki thi. Then he will scold me, why didn't you check it? Did you see the light is working? Did these people have adrenaline? Did these people have this and this? So sometimes those people may not be aware, but I see with an eye of this thing, whether they have brought that kit, everything is there, they not. As Rakesh is, rightly mentioned, in medicine, every patient is important, every situation is important, and the help, when the help will come, it doesn't come, it comes just of its own. It will not give you, that much insight that it is coming. So it's better to be prepared rather than to repent later on. Sometimes I remember one or two senior residents, why these people are calling, why these radiologists are calling us for this hada kam nahi aega. These are the terms, this is the truth. With over time, then they realize, this is very important. And I always say we work as a team because we don't work together, because we respect each other. And that's how our team is growing. And to me, it's very satisfying, and to the science, and this is the way forward. I always tell people better in a team. Yesterday, Yamini, I was talking with Yamini. She was telling me, it's a radiologist that we never want to sit together. And that's very true, but this is the thing that we have to change. If you have to change the things, then you have to change ourselves.
clinical questions. Like distal aneurysms that we have seen. Have you seen any giant distal aneurysms or like obvious ones on the 6 patients? What is the dimensions that they have?
You are asking a very difficult question from a manuscript which was published 2 years back, but yeah, giant aneurysms, there were aneurysms, large and medium-sized aneurysms. No one was giant aneurysm in those patients. But those CTCA was done in follow-up CTCA. So possibly they had a giant aneurysm in a distal part, and that has regressed for that I don't know. Circumflex we had
The proximal parts, but in the distal part. Second case has been discussed, like the peripheral aneurysms, almost always associated with the giant aneurysms of the heart. So when you see giant aneurysms, you may think of peripheral aneurysms and you may screen, but protocol is not clear. Similarly, these aneurysms, like distal aneurysms, do they have any correlation with the proximal aneurysm size? Like the giant aneurysms in the proximal has more association with the distal aneurysms, or they have never been associated with small aneurysms in the proximal side. Is there any correlation? So retrospectively, clinician may think that, okay, we have a giant aneurysm in the proximal side, this many % chance is there to have a distal aneurysm also. Such kind of clinical correlation, yes.
So we have not looked into specifically from that, but what literature suggests is that if there are very large aneurysm in proximal segments, the chances of having a distal aneurysm are more. But what we have seen in our patients in our study is that 4 patients had isolated distal segment aneurysms. But what they had in initial part was that very small aneurysm in proximal aspect and proximal segments, and they had normalized. But yeah, you are true that because most of the studies suggest that if you are having a very large burden of the disease in a proximal segment, the chances of having a distal aneurysms are high. So that is true.
But following an acute KD, what is the ideal time for doing a CTCA?
There are no guidelines or guidance on that part when to do CTCA during the acute phase, because guidelines talk about mostly about the follow-up CTCA. But what we are doing here is that once the child is stabilized, that we have treated for acute part of the settled. There are no fever, no hemodynamic instability, and everything in same admission at the time of before discharge, or maybe when we think that child is still not fit for the CTC we call them after 2-3 weeks. So its child should be stable enough to go for a sedation. So that's what we follow here, and we are in process of formulating our manuscript in acute phase of CTCA, which we have done around in 60 patients, approximately in 60 patients with and what we have seen is that the duration is very variable. So it starts from around 7 days to around 6 weeks, approximately 6 weeks. So but the crux is that we do CTCA when the child is stable and when we are comfortable. So it's not an urgent thing, but why we are doing CTCA during acute phase? One can say that what is the necessity of doing CTCA during the acute phase? Because there is a overall burden of the disease is high, so possibly you can increase the treatment intensification, possibly because what we are using is that when there is a giant aneurysms or multiple aneurysms, we give the multi-targeted therapy, including the IVIGs, steroids, infliximab, and cyclosporine. So what Japanese people use cyclosporine is for 5 to 7 days, but as US people use, like Jane Burns use around cyclosporine for 4 to 6 weeks. So similarly, we also use for around 4 to 6 weeks. So because cyclosporine has shown significantly in that coronary artery aneurysms can come down, which is shown in TICA trial also. So on that aspect, CTCA help, and sometimes if there is a suspicion of thrombus, so you have to do at that time definitely CTCA during acute phase, because that will also helpful. So its indications are it's evolving in CTCA, and possibly once we are in full manuscript, we'll be able to able to tell that what are the best indications in the CT scan during the acute phase of the Kawasaki disease?
In AHA 2024 guidelines, they have said that in case of giant coronary aneurysm, CTCA should be considered before discharge. So this is the line that is written in the latest 2024 guidelines.
Should be considered, may be considered. What AHA should or may?
May. I will check.
Sometimes from the patient side also what indications there. During the discharge, sometimes I used to tell them you are not.
CTCA, this modality can be used in patients with KD with expanding giant coronary artery aneurysm during hospitalization right before discharge to map out the extent of the aneurysms in the short term.
Can be considered. Can be considered, not should be considered. I think they must have deliberated upon this word. You know, the question which no one has asked and which I thought someone will ask is, what are the indications for doing CTCA in KD? So, since the first publication on CTCA in KD, we have had this nightmarish question from all reviewers. So, whenever you submit this publication, there is not a very pleasant set of questions which comes from the reviewers, and the question is, what are the indications for doing CTCA? Because conventionally, Kawasaki disease was synonymous with echo as the imaging modality. Conventionally, the teaching was Kawasaki disease affects only the proximal surface. No, that is not correct. Because if you restrict yourself to echo, you are only concentrating on the proximal or maybe some bit of the middle coronary. So that is how the conventional teaching built up. But the moment you have an imaging technique which goes on to the distal coronaries, then you start realizing, you realize that it impacts the entire coronary length. But what is the indication for doing CTC? When do you do CTC? We have struggled with this. And whenever the reviewers ask, you have to use all your literary skills to somehow frame an answer. Do you do it in all patients with KD? Do you do it in patients who have severe forms of KD? The latest AHA 2024 guidelines, they have, I think this is the first time that the AHA guidelines have mentioned CTCA in their original, in their, what will you say, as a definite indication. First time. Otherwise, in the 2017 version, it was quite vague. This time, there is a definite indication they have mentioned. But they have said that if there is some echo abnormality, you can consider. But suppose a child has had a very hectic PICU stay with KD, shock, macrophage activation syndrome, triple antidote therapy, infant, it's a small baby boy. From our perspective, we would almost always do the CTC in such a patient, even if the echo is normal. Even if the echo is normal. And the things that you see on CTCA, you can't even imagine seeing on echo. So this morning, we discussed with Dr. Suda, a patient, this was a 2-year-old child who had very severe Kawasaki. And this baby ended up having a left ventricular aneurysm. So he's infarcted, and almost 30% of the left ventricle has an aneurysm, which I don't think any echocardiographer in the world would have picked up. So at present, where we are doing CTC is all infants with KD, and many of them have very severe forms of KD. Any KD baby who has come to us late where we think that the chances of getting coronary abnormalities are high. That means after day 15, day 20, we will do the CTCA at admission itself. Any child with echo abnormality at admission, we will do the CTCA. And any others? And all children with very severe disease, we will do the CTCA. But there is no consensus on this. Because almost all manuscripts on CTCA that we have so far written, the questions from the reviewers are the same. With this AHA guideline, I think the question will decrease. Because now as part of guidelines, this investigation has come up as a recommendation, as a definite recommendation. Although they still have not used the word should. But I think it's a major advance. Can word has come. We are grateful to the AHA that maybe in the next version it can be converted to should.
So along with the coronary evaluation, can we calculate the ejection fraction just like MRI? The person the software can you do the EF calculation also?
No sir, because the protocol that we use is in PCD, because it is not on a helical scan. Unless you have all the scans from systole to diastole, so you will not have. And in majority of studies, the ejection fraction that comes from CT is not validated.
Yeah, here in pediatric population we do not use it because, but it can be done as in the MRI to some extent. These are no similar, but that is very easily seen on the probe. So that is not required because then increasing it with the retrospective grading will increase the radiation dose substantially. It will do it more than others.
And it's a more important, I'm happy to share that recently we have got our manuscript in archives of childhood, and that enumerates the indications of CTCA. And I think we should be getting good number of questions from that. And Dr. Pgimer, I assure you that with Dr. Supri, Dr. Rakesh, Dr. Arun, in the system, our manuscript is nearly complete on the role of CTC in acute phase of KD, and we are hopeful to submit it maybe in another 3-4 days.
But it was not an easy acceptance.
Yes.
That's also.
So it took
almost 11 months to convince the editors of archives.
Yes.
The indications for CTC. It took us very long to convince. Sir, the question that you have asked, I think, is a very important question. That how do you rule out systemic aneurysms in KD? So we have had maybe 1 or 2 patients so far in whom we have documented systemic aneurysms. But I remember there is a study from the US which says that systemic aneurysms can be seen in 1 or 2% of patients with KD, which is a very high number. But unless it's an axillary aneurysm which you can pick up by palpation, suppose it's an aortic aneurysm, it is not very easy to pick it up clinically. So we've had one aortic aneurysm and 1 axilla. Yeah. But I'm sure we must have missed many. But if you start doing the whole vascular access CT, the radiation will be unacceptable. So the aneurysms other than axilla, I think we must be missing. So popliteal aneurysms or femoral aneurysms, they will still be picked up. But other large arteries, I think we would be able to.
The morning case presentation from AIMS, I really appreciated that the micro aneurysms in the kidney showed
Yes, so now we have done, you can see our paper, landmark paper was in 2017 when we showed the role of CTC in polyarterial aneurysm. That will be the pediatric population. One thing, sir, I will tell you is very hilarious. Once I was in Yale University, I asked Professor Midani, sir, why do you do CAN? When you can do everything on CTC, he was laughing to me, yes, you are saying right, but we are accustomed to doing catheter angiogram and follow-up. Then I asked what information you get. We said we do OCT in that cases. We do, maybe FFR, right by FFR. But he was very much convinced, what we are doing has to change. So we have to embrace the new technology and see what the best is giving to us. And the things is the dictum is invasive to minimal invasive or non-invasive to minimal to minimize further. And I think we are moving in that direction, and also that we get our scans in much lesser radiation in this.
Actually, we tried very hard to get radiologists from other large volume KD centers in the country for this meeting. I know Dr. Saji tried, Dr. Priyankar and Dr. Devdatta tried from Calcutta. We tried radiologists from Delhi. We tried contacting the army cardiac radiologists. But I think we are very grateful to Dr. Srishti. She is the only radiologist who has joined us for this meeting. I think we should clap but we wanted more cardiac radiologists to be here so that they see how the procedure is done, and it will be a game changer. Any center who starts doing Vellore, Dr. Murugan and Dr. Satish, they I think tried convincing their senior radiologists, but somehow they couldn't. So any high volume KD center, they have to start doing CT and we were pleasantly surprised by the extent of damage that you see on CT angio and that you miss on echo, completely miss on Dr. Puni.
So I'm from BMC Ludhiana, and we have a very good neuroheart center. But CT angio is not done in any age group because the cardiologists are very, what should I say, they feel insecure that if the CT angio is being done by radiologists, then and they discourage us that it is not sensitive, it is not specific. So what I want to ask is, what is the sensitive difference between invasive angiography done by the cardiologist with CT angiography?
Right, that you take money out, everything will fall in the radiologist's right.
I also feel the same.
I tell you, Dr. Arun is here, he is from All-India Institute. I tell you, in our institute, diagnostic catheters is totally out. Only catheter angiograms that are done are only for, other patients whom they will intervene. Otherwise, diagnostic angiograms are out.
Sir,
so is already institute.
In our hospital, the cardio team is so strong, they don't let the radiologist. CT angio is not done in DMC, such a big hospital. So if we want to do any CT angio, there are private, very good radio centers who are doing it. So I want to ask is if we can get your help, at least for KD, they'll be scared to touch children and they know that pediatrics is not a money making thing. So maybe we'll start with CT angio from, we need your help and for CT angio children.
You just let us know. In fact, I will smell of it, I will come there.
So I'll need
That's not a problem. We are always there. There's no problem. May I request Ma'am Sudha to join me here? Ma'am Sudha, ma'am, can you please? I tell you our experience is. Ma'am, please. In NCVC, National Cerebral and Cardiovascular Institute, the catheter angiogram for KD children is almost out. What they are doing is all CT angiograms and MR angiograms. And ma'am, I just want to know about your experience in NCVC about CT and MR angiogram versus catheter angiograms. Sudha ma'am, I want to know what is your experience about the CT angiograms or MR angiograms vis-a-vis catheter angiograms, whether the catheter angiograms have decreased and CT angiograms are increasing your clinical practice, or it's just the same that was 20 years back?
The number of CAD very decreased and CT angio increased. But because radiation avoiding radiation increase.
what we could, it is very clear, unambiguous that CAGR have exponentially decreasing, and there is a high acceptance of CTC or MRC or in myocardial perfusion imaging depending on case to case. I think we have discussed.
To answer Dr. Puri's question, it is a very, very important question. Here they started doing CT angio in 2007.
2000, I came into this picture in October of 2008.
So that was the first time, the 64 slice CT scanner was installed here in APC. So that they started doing cardiac CT scans on that machine, which by today's standards was a primitive machine. But that was the first time. You can't do cardiac CTs on a scanner less than 64 slices.
We have, I think, more than 120. What are the highest is there?
Yeah, I know that, Dr. Kavita Sagar is
actually,
she has bought that Siemens 4. She was with me maybe 3 years back, and she requested me, madam, you just let me know I will come, but I don't know what has happened after that. In fact, Dr. Talwar, who was a cardiologist, pushed our head of the department to start the CT coronary angiogram.
So I'll give you a reference. And so what is the sensitivity test which says, okay, CT invasive and versus non-invasive, which is better?
No, after they started doing it, the number of invasive catheter angiographies done by the cardiologists, they have decreased drastically. Maybe as a rough figure, maybe 10 times less than what they were doing previously. After they started it, and it is so convenient, it takes hardly 2 minutes.
As a patient, you will never, if doctor's patient is there, then they will refer them outside DMC to get a CT angio. But inside our hospital, because of the strong cardio weight, so I think we'll push, pediatrician will push it.
That is a kind of, the change that has occurred.
Ma'am, what you tell in congenital heart disease, Dr. Arun is expert of congenital heart disease. I will request you to make a comment. Catheter angiogram is out. It is a CT angio. There is a way forward. You can have 3D models. You can have 3D reconstruction. Arun, can you make it?
I think I would also like to emphasize that Arun is the only radiologist in this institute who is a DM in cardiovascular radiology. He is the only radiologist.
Cardiology perspective, even the investigation of child for his CT is in congenital heart disease is for coronary evaluation, pulmonary artery sizing, evaluating aortopulmonary collateral. There is also a line that it is for rule out any anomalous coronaries. Many times we see on echo earlier, whichever surgeon always go for CT. They never take patient before. Either you have to get CT angio done or you do CAT. We will not touch the patient otherwise. So here it is the CT angio which is primarily being done and not the catheter angiogram. Catheter angiogram is only for whenever they require hemodynamic assessment. In congenital heart disease, I am saying.
Basically, they say that we are doing it as a one way because we might be needing stent, and more than half of the time stent may not be needed. So it's like a,
I tell you, ma'am, out of all the catheter angiograms which are diagnostic, 60% are normal. Out of them, 20% they don't require intervention. Probably still. We talk of science, all intervention has to be FFR driven, but that is something which is more of a theory, most of a theory. I think I have met good cardiologists who are very, very, they are convinced that CTC is the way forward, especially the patients who are low to intermediate probability of having coronary artery disease. And once we give them the disease, we tell them that this is the disease, this is the segment of the disease, rather than hunting in dark. They know it when they go before the gap. This lies the disease and this is the size of stent, this is the length of the stent. It is just like, driving a Mercedes-Benz Visa Bulla car, doing a catheter angiogram on the first instance.
So Dr. Srishti, you did the first few pediatric CTCs, so what difficulties have you faced there at AIMS Patna?
So first, we were doing for congenital heart diseases, but we tried to reduce the number of phases to reduce the radiation exposure, and we were not able, and we did not use ECG gating to reduce the radiation exposure. But with the protocols that Sir had us made, The scans are ECG gated, 2 phases, and then to the radiation is within limits. So with pediatrics, the first is the scan duration should be very less. Then was the other problem was heart rate, which sir had come to Patna regarding some conference related to Kawasaki disease. It was at that time when sir told us to contact him, and we asked our engineer to talk to sir, and then we made protocols, 70 kV, 80 kV and 100 kV protocols. So in children, like earlier we were using 100 kV for all patients, all CT scans. So now we have the 70 kV protocol and the 80 kV protocol. So right now we did a case for a 5-month-old child with congenital heart disease. We did a scan with the 80 kV protocol, and we got very good images, and the radiation exposure was also very less. Right now also 2 days before, just before coming here, I did a case with Epstein's anomaly. We got very good images because they were ECG gated, and the radiation exposure was also...
what was the radiation exposure?
That's a 1.2 millisievert. 22
that. And how did you sedate the baby? And who sedated the baby?
So that pediatrics people had done. So for the 5-month-old child.
Yeah, that is the way it has to be done.
Yes.
The pediatrics team has to be there.
So Pratap Patra sir was here actually,
Yes,
so
yes.
he helps in these cases.
So here, I mean, the scans are done in the presence of the radiologist, not the radiographer. Radiographer is there, but the radiologist himself has to be physically present there to tinker with the controls. And that is how you decrease the radiation to much less than 1 millisievert. With the latest machine that we have, the 384 slides, 386. So much less than 1 millisievert, which is about the lowest in the world, about the lowest radiation exposure. And the information that you get is, I mean, that has changed the way we understood Kawasaki disease.
I tell you, I get an opportunity by God grace or by whatever University of Bristol, University of California, and good centers across the world. You won't believe, how this imaging modality has come way, and it has generated so much of enthusiasm among the pediatricians, pediatric cardiologists, pediatric rheumatologists. How this imaging, which probably seems underutilized, can be the modality of choice or the standard of care in the days to come. So this, I would like to closing remarks from the professor and please.
So can I mention something?
Yes, please.
So in the eastern part, like I come from the eastern part of India, where in both the centers like Chandigarh and Narayan, we have developed a protocol, and for the last about 10 years, from 2015 to 2025, our cath proportions have been approximately 65 to 70% has been the interventions, and only 30% has been diagnostic. The diagnostics has mainly been limited to, as sir said, the prefontaine caths and the diagnostic ones where we had collaterals which had to be coiled, like large major aortopulmonary collaterals, or we did some oximetry hemodynamic studies where the hemodynamics was important because we had some late presenters, for example, large left-right shunt lesions presenting at the age of 2 or 3 years, or maybe large intraventricular ones before going for whether that can still be reversible or not, such cases. So those are extremely less now. We have a CT scan protocol. The sedation is given mainly by our pediatric residents who travel along with the patient, along with all the emergency medications, bag mask, resuscitation, everything. The radiologist and everyone is keep in standby. The radiologist mainly does the protocols. Most of our CT scans are protocol based, and we reconstruct the images, and we are happy to say that most of the reading is also done by us only, because we can see by our PAC system, we can read the CT scan before the radiology report comes, the point of interest like the branch pulmonary arteries or the relationship with the great arteries, or even the shape and size of the ventricles on all the cardiac structures can be read by us, because we have the facility in our desktops. So we have been adhered to this one. Yes, it's a welcome step, because mainly because it's apart from the fact that it carries a listing, it's always an invasive one. And do not forget that any invasive catheterization in a cardiac patient, especially in a child, can result in even death. Yes. Because we have had that one in severe PAH crisis and obviously it is an invasive procedure, so we try to avoid it as much as possible.
You know, the Madam Sudha, during my visit to meet with Professor Shiaishi, and Shiaishi is one gentleman who can probably will carry his name in the next birth as well. So after retirement, he has so much of funding that he is carrying on. He is an altruist, I can share, and is a philanthropist by heart. He is making pre-procedural prediction. You want to do Fontaine versus vis-a-vis you want to do an petition. You want to do a petition, it should be which arteries to be done, whether it should be single artery, double artery, and they will have your reconstruction mathematical algorithms. And at the same time, he shared one painful thing that people in Japan or the youngsters are not coming for CT-based surgeries. And same is worldwide, I suppose. He is making 3D models which you can cut, you can stitch them before you go to the operation theatre. So with this, they know what you are going to see on the table, and they have already practiced it. And once this happens, the 6 hours time for surgery reduces to 2 hours, and so is the results.
I have inspiration.
I requested that man, Dr. Shiaishi had connected me to the person who made his models in Kyoto, and he has showed his willingness to come to India, but currently he is focusing on Japan and Europe. I think if things goes right and everything is in place, we'll start at 3D modeling here as well, in which you can have a virtual dissection labs and virtual surgical labs. Yes, ma'am.
Just to mention that in American Institute they are actually doing this project of AI, and as far as I know very little, there is a project of AI where they are putting it, they are sort of taking it to the next level, combining it with computer games. So if you wear that headgear, you can actually transport it to that virtual world where you can see that particular diseased portion of the heart with that abnormal anatomy, like you said, and they can actually visualize that BSD or visualize that particular disease segment, the exact location. And there's also that bit where you can get a 3D printing by using AI with your inputs from CT and MRI and getting that 3D prints.
That is the way forward. I think we are lagging behind that, but we have to practically pursue it. But when you come next time to PGI, we'll show you that.
Thank you so much.
Yes, ma'am.
So what Devika ma'am was telling us, so we are involved in that VR project. So we have 2 of our headsets that are the Oculus headsets, and we have the software inside our systems. So once we connect with the systems, we don't need the systems after that. We are just with the headset, and one good CT imaging, we just inculcate into that headset and do the VR thing. So apart from those congenital things which we are doing in now, I've contacted Dr. Mahesh for that. So we are trying to incorporate if we can do anything for the coronaries for the same.
You invite us as to that. Yes, sir. Yes.
But the main important thing is you require a very good quality images. Good quality, and good quality comes with the radiation. That is something we have to need the increased kV. It is better for slightly more younger kids, but that is the main crux. If you have good quality images, it is very nice results.
And if invasive procedures come down to a very low level once we have those virtual images.
Yes. May I request, so with this we close our section, and thanks for your active participation. And thank you so much.
but फिर भी पता है
हो गया
Yeah, good evening. So we start the session now. So for this talk, we have Professor on statins, statins, beta blockers, and AC inhibitors, the role and safety in vasculitis.
Thank you. I took a case presentation. The clinical course of a 9-year-old boy with IVIG resistance is shown. He had an acute MI, and Elanapril is started. In this patient, CTA and MR shown. After RCA was occluded, segmental stenosis was detectable after 1 year after KD. In LCA, aneurysm regressed 1 year after KD. CTA imaging after 1 year was shown. In technetium myocardial perfusion imaging, hyperperfusion was left ventricle, but hyperperfusion was the inferior wall of the left ventricle was detected, but LVEF was 5%. Another case, the patient had anteroseptal myocardial infarction at the age of 3 years, and he underwent intercoronary thrombolysis. The next day, he underwent coronary artery bypass graft to the left anterior descending artery. He had an asymptomatic occlusion of the right coronary artery. He underwent percutaneous transluminal coronary rotational atherectomy due to severe localized stenosis of the left circumflex at the age of 14 years and 15 years. His obesity worsened his left ventricular function after 13 years of age. Pulmonary hypertension was suspected based on the peak velocity of tricuspid regurgitation on 2D. He had coronary risk factor including obesity and hypercholesterolemia. He suddenly fell down while working at the age of 35 years. His emergency coronary angiogram showed severe restenosis of the LCX. He had PTCRA and stent implantation for dissection of LCX. The right coronary artery was segmental stenosis. Although indication for CRT was considered, the QRS duration in his ECG was narrow. However, his LVEF did not improve. CTR was 60%. LVDD was 78 millimeter. A left ventricular assist device was implanted while he waited heart transplantation. The value of his parameters before and after LVAD implantation improved. Here we see an infant patient detailed. A 22-month-old boy, body weight 10 kg, had severe KD with IVIG resistance at the age of 4 months. Coronary angiogram at the age of 6 months indicated bilateral giant aneurysm. At 22 months, he suddenly became pale and had syncope while walking morning. He was evaluated at the hospital 5 hours after the episode. Abnormal cube wave were present in lead 2-3 AVF of his ECG. Hypokinesis of inferior cardiac wall was detected on 2D echocardiography. He was admitted to hospital in the afternoon, and the next morning he became pale again with hypertension, STD depression in V1-6 and noted on ECG. He was diagnosed as having acute myocardial infarction. Although ICT was performed, his condition worsened in the evening. Cardiomegaly and pulmonary edema were seen on chest X-ray. He was transferred to our hospital. He underwent coronary artery bypass grafting to the LAD with the left internal thoracic artery 1 month after his acute infarction. Coronary angiogram 25 days after surgery indicated complete occlusion of the proximal portion of the LAD with the distal LAD flow supplied by LITA. Although coronary CABG improved perfusion of anterior wall of LV, BNP increased more than 1,000 picogram per milliliter again, and the LVEDP was elevated after surgery, suggesting a transient worsening of heart failure. Very low dose carvedilol was started. The LVEF improved. A high brain natriuretic peptide value persists because of a low left ventricular ejection fraction, but BNP eventually decreased after medical treatment, including very low dose carvedilol. The slide showed the parameters of his cardiac function. Beta blocker and ACE inhibitor, very useful for heart failure after myocardial infarction. BNP 409 to 28 decreased to 28. LVDD 42 millimeter to 39 millimeter. Mild regurgitation, moderate to slight. The slide shows the finding of 2D. In myocardial perfusion imaging, myocardial ischemia was improved after coronary artery bypass grafting. However, he had syncope in 15 years old. Skull CT was normal. 1 month after CT revealed aneurysm of the left ventricle. Warfarin was added and subcutaneous ICD was inserted. Chest X-ray and his electrocardiogram are shown. Japanese guideline is shown. Low dose carvedilol 0.01 mg per kilogram was not tolerated by this patient 3 months after surgery. Then his BNP level was more than 500 picogram per milliliter. However, it became possible to tolerate 0.002 milligram per kilogram carvedilol when his BNP decreased from 300 picogram per deciliter in response to increased diuretics. Time to required for patient with a low ventricular ejection fraction after widespread myocardial infarction to adapt to beta blocker. If introduction of low-dose carvedilol is unsuccessful, a very low dose should be tried. Introduction of very low-dose carvedilol decreased the value of BNP, and LVEF improved. The BNP level is a good guide when starting and adjusting beta blocker therapy. In patients with low LVEF, it's easy to measure and sensitive for heart failure. If introduction of low-dose carvedilol is unsuccessful, a very low dose should be tried. Introduction of very low dose carvedilol decreased. The value of BNP and LVEF improved. Very low dose carvedilol helped improve his severe post-operative heart failure. Thank you for attention. Thank you.
Thank you.